Well, good morning. Appreciate all y'all being here. Morgan's still putting out the name plates here, but we appreciate everyone in attendance today and appreciate the hospitality of Augusta University and all the staff and the President King. Russell's been a longtime friend. I've known him for probably 18 years when he was at the Capitol doing other things and watched him rise to the ascension of president of Augusta University. And so you have a very wonderful president and a man that knows how to get things done and what's important and focuses on those things. So I would like to say good morning to the committee and thank you again. This is our third meeting of the Cancer Access Committee, Access to Cancer Care. We're focusing on rural and minorities, but also cancer care in general, trying to see what we can do to increase the access in this state. We have quality care, and we know that, but without access, the quality care sometimes it lacks a little bit for our citizens. I would like to start off beginning with introducing the committee. If you would introduce yourself and say your profession, starting on the left with Jenny. Oh, Jenny, hit the, use the mic, please.
I'm Jenny Wren Denmark from East Georgia Healthcare Center, a federally qualified health center based in Swainsboro, Georgia.
Hello, I'm Doug Graham. I'm a pediatric leukemia physician, and I'm the chief of the Aflac Cancer and Blood Disorders Center at Children's Healthcare of Atlanta.
Good morning. My name is Jorge Cortez. I am the director of the Georgia Cancer Center here at Augusta University.
Chris Kiker. I have the privilege of being a family doctor in Toccoa.
Morgan Hall. I'm the analyst for the committee.
And a very good analyst and someone that we all depend on in this committee. I'm Lee Hawkins. I represent the 27th District, that's in North Georgia, and chair of the Health Committee in the House.
I'm Karen Mathiak, and I represent the 82nd District, which is Spalding and Fayette. And I'm really excited to be here today. I think that we're going to learn a lot. So thank everybody for being here.
Hi, I'm Kristen Higgins. I'm a radiation oncologist and the chief clinical officer at City of Hope Atlanta in Newnan, Georgia.
Good morning. We're glad to be here at the Augusta University. I'm Gerald Green. I'm from Southwest Georgia. I'm chairman of state properties and been a state representative for a while.
Just a minute.
Hey, good morning. I'm Spence Mullis. I'm chairman and CEO of Morris Bank based in Dublin, Georgia, and I'm a cancer survivor.
Thank you, committee. Now we'd like to hear from the president and welcoming remarks. President King.
Well, good morning, and
morning.
Welcome to Augusta University and welcome to the Georgia Cancer Center. This is your cancer center. This is your university. And Mr. Chairman, Karen and I enjoyed being with you and the entire committee last night and hearing your passion and enthusiasm for the question at hand, and that's access to care. You know, this study committee on cancer care access is something that's near and dear to our hearts at Augusta University and the Georgia Cancer Center. We wake up every day and we go to sleep every night thinking about how we can improve every interaction, every opportunity that we have with our researchers, our clinicians, and most certainly our students and our patients. What you're doing here today is very important, and it's relevant because in 2015, the Georgia Cancer Center was formally formed, and it was formed by the merging of our research and our clinical practice. In fact, when you go outside of this building and look to the right, you'll see a literal bridge that is a figurative example that will remind you every time you go in and out of Laney Walker over here, that there is a connection between the research that we do in the laboratory and translating that bench to bedside to the bedside of our patients right here at Augusta University. There's a lot going on right now and a lot of conversations about research in our country. And I want you to know that the research we do here at Augusta University saves lives, changes lives, and prolongs lives. In a room like this, oftentimes I will ask folks, how many of you have been affected or impacted by this disease we call cancer? And most of the hands will go up. And then I'll ask the question, if you had the opportunity to cure this disease, maybe not today, but for tomorrow, maybe for your family or for your great grandchildren or your great grandchildren with whom you'd never meet, if you had the opportunity to invest today to ensure that they wouldn't have to fight this disease, would you do it? And overwhelmingly, the heads nod yes, we absolutely will. We know that we would not be here today without the partnerships that we have with our elected officials. You all have supported this cancer center since 2006 with really over about $150 million of capital projects, which make what we are today. But you also last year funded $99.8 million for a translational research building at Augusta University. And there's no greater example of translational research than what we do right here at the Georgia Cancer Center. I want to tell you that we are grateful to have you as a partner. The strategic funding initiative that you continue to fund for this institution and for this cancer center has been profoundly impactful. And we've told folks that we've done a lot more with less, but it is time for us to do more with more. As a state, as a people, as a partnership, we have no greater partnerships than that can be identified with our partnership with the General Assembly, but also with Dr. Lynn Durham and Georgia Core and her entire team for what they do to connect the assets that we have statewide to provide care and research to cure this disease. We also have a number of our partners that are in the community here. The Georgia Higher Education Healthcare Initiative was profoundly impactful in helping us raise an unprecedented almost $30 million to match that $99.8 million to form this translational research building. So I hope in the future that you all will come back here and you will know that our faculty, our clinicians, our researchers are here for you. And that's for you all on this committee, but it is also for you all that are here today sitting in the gallery here. This is your cancer center. This is your university. We have a statewide mission, and the impact that you all are having to study how we can provide greater access is extraordinarily important to each of us here today, and we look forward to being part of the solution for many years to come. So thank you all for being here, and welcome to Augusta.
Again, thank you for your hospitality. We really appreciate it. Okay, let's go ahead and begin. We're going to be on a tight schedule. We're going to finish this at 12 o'clock. We'll have some tours after that for those committee members that have time and wish to do that. I do realize that you have another thing to do in your life, and that is your profession and your work at home. And so if you have time, that would be great. If you don't, I understand. Okay. Our first presenter is going to be on the impact of cancer research by Dr. Nikolinatos. I probably murdered your name, and I apologize. You go to the podium there.
Good morning, Chairman, and distinguished members of the Senate Study Committee. My name is Petros Nikolinakos. They call me Dr. Nick for obvious reasons. And I'm a practicing medical oncologist and the managing partner and president of a private practice in Athens, Georgia. I represent a minority point of view in the state. We're part of a very small number of private practices left in the state. It used to be where we were plentiful. But this is a unique perspective. We're not an academic center, despite the name of University Cancer and Blood Center, and we're not a hospital-based practice. We're truly independent as a practice, and we've been independent for the last 40+ years in the state of Georgia in Athens. I'm honored to speak to you today about a critical issue affecting our state, access to cancer care, and my goal is to highlight the invaluable role of independent oncology practices in ensuring high quality, affordable, and accessible care for Georgian patients. Our practice has proudly served the cancer patients of Georgia for over 40 years now. As I mentioned, we are dedicated to bringing comprehensive cancer services to rural Georgia. We operate in the northeast of the state, over 11 locations throughout the state, and we have a large award-winning clinical trial and research program We have about 80 clinical trials, including phase 1 trials 2 and 3, and we ensure our patients have access to cutting-edge treatments closer to home. Our commitment to innovation is reflected in our rapid implementation and adoption of the most advanced therapies, despite being a private practice, including being one of the first in the country to offer a comprehensive theranostics program and prostate cancer treatments, and now running one of the largest theranostic treatment programs in the country. We have 25 doctors. We have 12 medical oncologists, 2 radiation oncologists. We have 6 surgeons in our practice. And we serve our patients comprehensively. We have a palliative care program in-house and a large social work program and navigation program for cancer patients. We expanded into this multi-specialty care in 2023, bringing specialized services such as breast surgery, colorectal surgery, advanced GI, and surgical oncology to Athens. One of our main sort of understandings is that there's a profound financial toxicity that cancer care can impose on patients and their families. In recognition of this, our practice personally provided over $8 million in financial assistance to our patients in 2024 alone, demonstrating our commitment to ensuring access to care regardless of financial burden. And we also have a couple of foundations that we initiated to help patients in need. I wanted to highlight the cost advantage of private practice, specifically just to highlight the importance of independent practices in Georgia. We love our academic centers such as MCG and UGA, where we are closer in Emory, but we believe that the majority of the cancer care delivery is performed in the community, where 80% of cancer care delivery is actually given, 80%. Independent oncology practices consistently offer more cost-effective option for all services, chemotherapy, imaging, and so forth. A paper in the New England Journal of Medicine 2024 highlighted this and highlighted that the cost can be 4 to 6 times higher in a hospital-based setting for delivery of cancer care, adding substantially to the out-of-pocket cost for patients and burden on private and public payers. That includes imaging, chemotherapy, and a host of other services that we provide, as well as hidden burdens, even parking. It's seemingly minor. The cumulative cost of parking fees for frequent chemotherapy, radiation, or follow-up appointments at a hospital can become a substantial financial burden to practices. A small thing like that can mean a lot to patients, especially where I come from. The notion that higher cost equates to higher quality is often a misconception in healthcare, particularly in oncology. Independent oncology practices frequently provide highly personalized, patient-centered care. Our physicians often have more time with patients, fostering stronger patient relationships, leading to more coordinated and effective treatment plans. Quality of care of oncology is measured by outcomes, patient satisfaction, adherence to evidence-based guidelines, not by the price tag, but by the quality. Our focus remains squarely on the patient and allows for agile decision-making and direct patient advocacy. I wanted to highlight a little bit the impact of the CON law changes that happened last year for the PET-CT services, especially in Athens. Before the CON law changes in Athens and many other communities across the state where we serve 60 counties, patients face significant delays in accessing basic imaging, such as PET-CT, for staging and for planning of care for a variety of cancers. We're talking about 3 to 4 weeks of delays in diagnosing patients and starting treatments. These delays were not only inconvenient, they directly impacted timeliness of diagnosis, staging, and monitoring of cancer. Patients often had to travel long distances, adding to their financial and emotional burden and further delaying care. We had a long battle trying to get that law changed for several years. I didn't realize how difficult that would be. Trying to get a scan a lot sooner required actually a lot of change. The ability of private practices like mine to bring PET-CT services has been nothing short of transformative in the community. It has drastically remedied the issue of PET scan delays in Athens, improved access, allowing quicker diagnosis and precise staging, reducing patient travel, stress, costs, enhancing the overall patient experience. And it's a clear example of how thoughtful regulatory reform can directly improve patient access to life-saving care without compromising quality and at a markedly lower cost, perhaps 3 to 4 times lower cost. Building on the success we've seen with PET-CT services, we strongly advocate for hopefully lessening of the CON laws of all cancer-related services to provide good quality care in the ambulatory setting, the community centers around the state and around the state of Georgia. Eliminating these requirements for CON for these essential services would further foster competition, drive down costs, significantly expand access to specialized cancer care closer to where patients actually live, particularly in underserved areas where we strive to provide care. This reform would empower independent providers to innovate and respond more rapidly to patient needs without bureaucratic hurdles, ultimately benefiting all Georgians facing a cancer diagnosis. Studies consistently show that cancer care delivered in community oncology settings is significantly more cost-effective. For example, research has indicated that the cost for patients receiving chemotherapy in a hospital outpatient facility is about 60% higher than what is delivered at independent practices. I mean, it is a significant value proposition for the state, for the payers, for the country to keep these independent practices viable and successful. To survive for a private practice like mine and continue offering these cost-effective, high-quality services that must be empowered to provide comprehensive range of cancer-related services that patients need. Without the ability to offer similar services as hospitals, independent practices face increasing pressure, leading to continued mergers and hospital acquisitions. This consolidation is frequently followed by significant price increases for patients and payers, often without a corresponding improvement in quality of care, ultimately undermining access and affordability. Finally, I would like to say that independent oncology practices are vital to the healthcare landscape of Georgia. We do offer high quality, not just my practice, but the few remaining independent practices in Georgia, patient-centered cancer care at a significantly lower cost than other systems, as evidenced by data on drug pricing and elimination of ancillary fees. Furthermore, the recent CON law changes empowering private practices to provide essential services like PET-CT have demonstrably improved access and outcomes for our patients. I hope and I urge this committee to recognize and support the critical role of independent oncology practice in ensuring that all Georgians have equitable and affordable access to the best possible cancer care. And I realize a lot of this is a little controversial. I'm in a room full of hospital executives and academic leaders who I have enormous respect for, but I would like to, as a minority representative in this state, I would love to shine a little light on the role that private practices still play in the state. So thank you for listening to me and acknowledging our presence in the state and our importance. Thank you.
Okay, thank you. And up next is our second presenter, Kristen Higgins, Clinical Trials Outreach to Rural Georgians. Excuse me, and also we have Grant Carrot. Crane, okay. Oh, yeah, Crane, sorry. Excuse me. We just had Representative Silcox make it to the meeting. Would you like to introduce yourself? Sorry about that.
Thank you, Mr. Chairman. I got a tour of the campus here because I came in and the receptionist was helping you guys in the meeting. And so I was here and then someone else directed me across the street. So then I got a tour of the clinic and they sent me back over here. So I sincerely apologize, but anyway.
Well, thank you for coming
Great
from
to be
Atlanta,
here.
and I appreciate it.
Thank you.
Thank you very much. All right, Kristen, go ahead.
Right, thank you. So I am Kristen Higgins. I am a radiation oncologist, a professor at the City of Hope National Medical Center, as well as the chief clinical officer at City of Hope Atlanta. So I wanted to start by just telling everybody about City of Hope. We're a newcomer to Georgia. City of Hope was started outside of Los Angeles over 100 years ago, and it is an NCA designated comprehensive cancer center. We have close to 900 clinical trials right now, near 1,000 physicians across all of our sites, and excellent outcomes for cancer care. City of Hope is now a nationally integrated system, and this is a map of our different centers. As you may know, City of Hope acquired Cancer Treatment Centers of America in 2022, and then transitioned these centers to non-for-profit cancer centers. I came to City of Hope in January of 2024 to lead our Atlanta location, which is actually located in Noonan, Georgia. At City of Hope Atlanta, I think one of the things that makes us unique is that we provide all of patients' cancer care under one roof. We have our ORs, our ambulatory clinic, our hospital, our imaging. All of those services are conveniently located for patients. As you know, navigating a cancer diagnosis is very difficult, so having everything under one roof really makes it a lot easier for our patients to navigate. So I wanted to just tell you and provide an illustrative example of what our patients go through. I'm going to give you an anecdote of a patient, patient Atlanta, who resides in an urban environment. And this patient had been a lifelong smoker, but quit smoking about 5 years ago. In May of 2024, he was referred by his primary care physician for a lung cancer screening CT, and they found a left upper lobe mass along with enlarged lymph nodes in his chest. They quickly were able to get him into an interventional pulmonologist. A week later, he was scheduled for an EBUS and biopsy of these lymph nodes. He then got a PET CT and a brain MRI, and collectively he was diagnosed with an unresectable stage 3 squamous cell lung cancer. He sought multiple opinions across his state and a neighboring state to really understand what his best option would be. I saw this patient at the end of July. I offered him treatment on a clinical trial for his lung cancer, and he visited me with his wife and was able to digest the material, share it with his family, and make the decision to enroll in this clinical trial. And he began treatment in August of 2024. He was treated on NRG Oncology LU008. For the committee members, NRG Oncology is one of the cooperative groups that is funded by the National Cancer Institute. And this group conducts clinical trials across the country. This is a trial for lung cancer, a phase 3 trial, where a patient enrolled and was then randomized to the standard of care treatment versus an experimental treatment combining a more conformal type of radiation termed SBRT that is more effective in treating lung cancer in earlier stages, but hadn't been tested in stage 3. He completed his treatment successfully on this clinical trial. I told him that I thought many times cancer treatment is best on a clinical trial because you have built-in navigation. You have touch points with clinical research coordinators almost every day throughout your treatment course. And that's really significant, and it offers a lot of support for patients and their families as they're going through cancer treatment. Now, I want to contrast patient Atlanta with patient Cuthbert. This patient resides in a rural environment. He again had this history of tobacco use. He, in May of 2024, presented with a cough, was seen, got a CT scan, and it showed an abnormality in his right upper lobe. They weren't sure what it was. He was treated with antibiotics and steroids. They elected to repeat the imaging. He was ordered for a CT scan in about 6 weeks. He couldn't come in 6 weeks because he had no ride. The CT scan was pushed out to 12 weeks when he could get a family member to bring him for that imaging test. It did look larger on this second CT scan. He was recommended to get a biopsy. Unfortunately, there was no interventional pulmonologist in his community, and his clinical team struggled to find an interventional pulmonologist, and it took many weeks to get him in to see somebody in Atlanta. He did ultimately get that biopsy in November of 2024, and it showed squamous cell carcinoma similar to our other patient. He then needed the PET CT. It didn't get done until December. There was a 2-month delay due to insurance, as well as due to a cancellation of a scan because of transportation and other issues. When he ultimately got that PET CT, he had a stage 4 cancer that had spread to his liver. And so now his treatment is palliative. He's not able to be cured from his lung cancer. And these are real patients, and these anecdotes happen every day. And you can see his workup took 7 months compared to the 3 months for the patient that was from Atlanta. And that's significant. By the time he was diagnosed, his cancer was progressing rapidly, and his care team didn't feel that he had the time to even investigate clinical trials for his cancer, and he had to just start on standard of care. And this is the reality that our patients face every day. And I think we can learn a lot from these patients. We know that speed matters. With these delays, the cancer progresses. You go from a stage 3 to a stage 4, and that is life-changing. We also know that we don't have sufficient community resources. We don't have these referral bases. We don't have interventional pulmonologists, people that can biopsy these cancers in a rapid fashion. And that is something that is desperately needed. Of course, your first chance with cancer is your best chance. So we have to get these diagnoses in a fast manner. And then we have to get patients to multidisciplinary care teams. And then the fact of the matter is, if patients don't have rides, they can't get the treatment that they need. This is a common theme that keeps coming up, I think, in multiple meetings, is that transportation is a low-hanging fruit, but it's so necessary for these patients to access life-saving treatment. And then lastly, clinical trials. Clinical trials can be the difference between life and death. This is how we're advancing the field in lung cancer, is by all the clinical trials that have brought new therapeutics to standard of care. And we want our patients to be able to access these. And so when we think about rural and community hospitals, how can we impact oncology care in Georgia? The onus is on us as oncologists to make a difference. We know that cancer incidents are lower in rural areas, but mortality rates are higher. And many times that's due to limited oncology services, things like bone marrow transplantation, multidisciplinary care teams in lung cancer and other solid tumors, subspecialty surgery options. And then, of course, patients having the transportation to get to these appointments that can occur many times in a sporadic fashion, spread out across a week, 2 weeks' time. It's very, very difficult. City of Hope has served over 2,500 patients from rural counties, but we need to do better. Some of the things that we've tried to do to solve this problem is coordinated care agreements with our rural partners. We have 3 right now, and what these involve is patients coming to see us at City of Hope. We put together a care plan, and then we collaborate with their local doctors for the care plan to be executed at their local hospital. We're trying to keep as much of the revenue in the local community as possible, because we know that these rural hospitals need that to continue to exist. And then, of course, educating patients and everybody around them for the importance of what patients need throughout their treatment. And so what are the proposed solutions? Of course, this is what we're here for. One of the things that I think we could think about is aligning on a core set of values for our patients with cancer. A Cancer Patient Bill of Rights has been a success in other states. City of Hope has supported it most recently in Illinois in 2024. And certainly I think we can all agree about the fact that patients deserve access to precision medicine. They deserve access to early and late stage clinical trials, but they also should be able to get high quality care in their community with this partnership with academic centers. And that's the part that I think we could really focus on together. Certainly, we've talked about prevention throughout these meetings, but again, if a patient wants to be screened, many times they can't come to the hospital for screening. So we really need to come together with mobile screening vehicles so we can get screening to the patients in their community. City of Hope has a screening vehicle right now in California. We're working to get one in Georgia. We don't have it yet, but it's one of our major goals. And then again, how can we collaborate with our community practitioners when we're developing care plans for patients with complex cancers? I wanted to talk about Access Hope, which is a subsidiary company involved with second opinions for City of Hope. And what we have developed is this collaboration between NCI designated comprehensive cancer centers shown here. And it's a product that comes through the employer. An employee then has access to Access Hope and can get a second opinion. They submit their records. Within a few days, the team reviews the proposed cancer plan and communicates with the local doctors to see if there should be any changes based on best practices. And right now it's available to about 5 million patients through their employer. About 150 companies are involved in Access Hope. And then again, of course, access to clinical trials. Even if a patient is able to access a center that has clinical trials, The other issue is, can the doctor have the time to find the clinical trial for the patient? Because these are very complex trials. The eligibility criteria is changing. Sometimes there are slots available for patients, sometimes there's not. At City of Hope, we've created AI-based technology to help our practitioners find clinical trials for patients in a very rapid fashion. This is something that we're integrating into our EHR to just really take the burden off the physicians when it comes to determining if their patient has a trial that they're eligible for. And these are other ways that we can use technology, again, to provide access to trials for all of our cancer patients. And that is my last slides. Happy to answer any questions.
Thank you. Okay. Up next, Crane Garoth.
Yeah.
Well, he's getting that squared away. Thank you all very much. Thank you, Chairman Hawkins, for having this discussion, having this committee. It's great for Georgia. It's great for our field. My name is Crane Garrow. I'm a medical oncologist. I am part of Georgia Cancer Specialists, which is part of Northside Hospital Cancer Institute. I practice in Marietta and I practice in Canton. Marietta, you could say, is somewhat suburban, and then Canton we consider somewhat rural, but yet clinical trials are part and parcel of our day-to-day activities. So my goal today, and what Georgia Corps sort of tapped me to do, is talk about cancer research in Georgia and clinical trials and how that's has outreach to the rurality of our state. One of the things that's been ingrained in me and probably all cancer researchers is that the clinical trials that we do today set tomorrow's standard of care, and that's how we advance our field. And so I wanted this to be the take-home message, but I wanted to put it first to frame it into the concept, the whole talk. So a little bit about the basics of research for oncology. One thing that a lot of people don't know is we do everything by data. We never make anything up. We never just think something's going to work and try to use it. We have to have data that show that benefit is greater than harm. And we do this for surgical treatments, for radiation oncology treatments, as well as medical oncology treatments, and especially chemotherapy, given the harm of chemotherapy. And so it goes like this. You have phase 1 clinical trials, which really look for drug safety and maximal tolerated doses. You have phase 2 clinical trials that look for signals of efficacy in specific diseases, and those are smaller clinical trials, usually 30 to 50 patients. But then you have phase 3 clinical trials, which test new drugs and combinations and really look for new standards of care. And it is true that phase 3 trials most often will establish a new standard of care if the investigational part of that trial beats and wins over the standard of care that was of yesterday. And that's how we advance our field. So research across our state, we have many major medical centers, obviously Emory, NCI designated research institution, and also MCG, Georgia Cancer Center here. Multiple practitioners from that institution are here. A lot of other large health systems that dominate the northern part in the Atlanta area. But even those systems have many, many offices and many smaller hospitals that are outside of the perimeter of Atlanta. So, Northside has many offices that are 200 miles from Atlanta. So we do have outreach, even though those hospital systems dominate in the urban areas. Other centers, Dr. Nick is from UCBC. They do a lot of research, as well as the Lewis Cancer Research Pavilion in Savannah. And City of Hope as well. So a lot of things come from the hubs, but then you have the spokes, right? And that's where the smaller medical centers are. And I went through the internet and the maps, and I tried to find as many small medical centers as I could. So if I did not have your medical center that you may represent or come from, please pardon, but there wasn't enough room on the slide for all of the smaller medical centers. And typically those medical centers are going to have smaller numbers of doctors, but they still have access to clinical trials. And that's the key, is that many of these smaller, more rural areas do have access to clinical trials. And I think that's a feather in the cap for Georgia. So by the numbers, the American Cancer Society estimates that we have about 66,000 new cancer cases in 2025 in our state, and about 19,000 deaths. Approximately 2,000 to 2,500 patients are enrolled on treatment-based clinical trials. Now, there's a whole lot of other clinical trials that are observational or registry, ones that are looking to just gather data, but not actually for a treatment against cancer. And so I did sort of hone this down. Now, I will submit to you, and please don't put this number in the internet or the social media, because this is an estimation that I made back of the envelope by talking to a lot of the researchers in our state and kind of coming up with a generalized number. This is not an exact number from some tabulated form. This is me actually calling my friends around the state and asking for help. So Emory has about 1,200 treatment cases per year. The rest of the other institutions comprise the rest of the cancer clinical trial enrollments in the state, and that's about 3.5% to 4% of the cancer cases this year. So we're somewhat behind what you can see as the national average, which was just sort of updated last year. We used to think that the national average for clinical trial enrollment was somewhere between 3% and 5%. But last year, there was a publication that indicated that treatment clinical trials represented about 7%. So we need to do better in our state. But how does it break down in terms of the number of trials we have open for us? If you look at clinicaltrials.gov, which is the major registry for clinical trials, there's over 650 open clinical trials in Georgia. Most of these are phase 2 and phase 3, which are very good. Breast, lung, malignant hematology, which is your leukemias and lymphomas, that Dr. Cortez and Dr. Jalella oversee, those clinical trials predominate, and gynecologic oncology as well. But one thing that's very good about our state is we have a number of institutions that conduct phase 1 clinical trials. Phase 1 clinical trials look, as we said before, for drug safety and maximal tolerated dose, and it's really where drugs are born. Because if they don't make it through phase 1 clinical trials, they never make it to market. So it's a kudos and a feather in our cap in Georgia to have phase 1 clinical trials. Another feather in our cap in Georgia is that we have something called the Georgia InCorp. This is the NCI's program. It's called the Community Oncology Research Program. And it's a way for the NCI to interface with non-academic medical centers to bring NCI-based trials to the community. And InCorp works to design and conduct clinical trials for cancer prevention, support care, surveillance, health-related quality of life, but also more importantly for treatment clinical trials is an organization called the National Clinical Trials Network. And Georgia is very lucky that we have 2 InCorps based in our state, one based in Atlanta and one based here at Augusta at Georgia Cancer Center. That's the Georgia Cares InCorp. Oh, okay. Fast forwarded too many slides there. So the function of this, and you can see down at the bottom of this slide that the InCorp site participation area, they interface with all of the cooperative groups. A cooperative group is basically a consortium of large academic medical centers who have banded together to say, we want to investigate certain diseases and do so in a very coordinated fashion. So you have SWOG, which is the Southwestern Oncology Group. You have COG, which is the Children's Oncology Group. You have NRG Oncology, which is the Radiation Oncology Consortium, and ECOG, which is the Eastern Cooperative Oncology Group, and then Alliance, which is sort of spread out over the country. And so these cooperative groups orchestrate large clinical trials, many phase 3 clinical trials, and we can access that through the InCorp and bring those clinical trials to the rural areas, to the offices, and to the medical institutions that are associated with InCorp. And this is a list of the organizations associated with the Atlanta Northside InCorp, and our principal investigator is Guy Cantonuria. So you see there's a whole ton of sites that can access those clinical trials. And this is the Georgia Cares InCorp that Sharad Gamande, who is one of the researchers here at Augusta Medical Center and Georgia Cancer Center, is in charge of that InCorp. You see a number of other sites that can access trials through there. So over the years, these are national numbers. InCorp has helped many thousands of patients enroll in clinical trials. So this is not Georgia numbers, obviously, this is national numbers, but we participate with 2 sites of InCorp in our state, which is really wonderful. And this slide just depicts the breadth of the InCorp program throughout the country. with only a few states having a couple of sites, but we have 2. And this really does facilitate access to large, diverse patient populations, racial and ethnic minorities, and rural populations. So I wanted to talk a little bit about the pace of discovery, because I think a lot of people don't really know what's going on therapeutically in our field. It's like a deluge. It's like we have to work to keep up because we have so many new drugs, and there's new drug indications every month. I oversee a committee called the Quality Research and Therapeutics Committee in Georgia Cancer, and we review every new drug every month, and there's at least 2 to 4 new drugs every month. And we review new indications, meaning that a cancer drug that was used to treat one cancer was then later tested at another cancer and has a new indication. So you can see in the pictorial on the right that between January of 2000 and October of 22, we have over 500 new drugs and new indications. So just a tremendous amount of growth in the number of agents. And also the mechanisms of action. And I'm going to get a little scientific here, but I think you need to hear this, that we are no longer really researching what we call cytotoxic chemotherapy, or I call it old school chemotherapy. We are looking at new agents that are just amazing in their mechanisms of action. There's something called bispecific T-cell engager monoclonal antibodies that are being used for many different diseases, chimeric antigen T-cell receptors, chimeric antigen receptor T-cell treatment, and small molecule inhibitors. Immunotherapy alone has really just blown up over the last 10 years, and we're using immunotherapy for almost every cancer. Antibody drug conjugates are a new way of delivering medical therapy to tumors with a monoclonal antibody with a chemical attached to it that is like a Trojan horse type of treatment. And then radioligand therapy, which uses radiation given intravenously. It's really fascinating. And then we've been using in our clinics next generation sequencing of tumor DNA. And this has become ubiquitous now, but what it has done is led to an enormous rise in the number of targets that can be pinpointed. Next generation sequencing of tumor DNA is when you do a biopsy, you send the biopsy to a company, and the laboratory sequences the DNA of the tumor and finds the DNA that can be targeted by a drug, or perhaps a molecular target, a protein or a receptor that can be targeted. This has led to a huge number of clinical trials and new molecular agents. So I wanted to give a little clinical trial success story in just a minute. I treat a lot of metastatic bladder cancer. I do a lot of genitourinary cancer. And classically, we've treated this with chemotherapy, and it was modestly beneficial. But in November of 2023, there was a published report of a clinical trial, which was a phase 3 clinical trial that had about 800 or 900 patients, so a huge clinical trial. And they pitted chemotherapy versus a new combination of therapy with an antibody drug conjugate called enfortumab vedotin and a immunotherapy called pembrolizumab. Many of you may know that as Keytruda. That's a common drug now a lot of people are aware of. Well, the combination of enfortumab and Keytruda dramatically increased the number of people who went into remission. The number of people who went into complete remission was more than doubled. It was astounding. There was a standing ovation at the meeting where it was presented. The overall survival was almost doubled compared to chemotherapy. So this was immediately a new standard of care in our field. And we knew it as soon as we saw the data. Look at the phone. You know, the common joke in our field is you have to look at your phone every day to see if there was a drug FDA approved yesterday that you can use today, right? So this was one of those, like, immediately you knew it was a benefit. You're looking at the number of trials that are opened through clinicaltrials.gov. This would be a national and even international registry. I started my fellowship in 2004, so 21 years ago, right? And at that time, there was probably 8,000 or 10,000 clinical trials available through clinicaltrials.gov. Now there's over 500,000. It's logarithmic, the number of trials that are open and available through clinicaltrials.gov. This is not for Georgia. This is nationally and internationally. So how do you find a clinical trial? And Dr. Higgins touched on it a little bit. And I like the whole AI thing that's going to really advance our field a lot in terms of finding clinical trials. But I had an experience in 2021 where I was taking care of a woman who was 45 years old in my Canton office, and she had colon cancer. It was metastatic. We had treated her with all of the standard of care options. And we got to a point where we had few options left, and I started reaching out, and we didn't have a mechanism to find a clinical trial for her. So I was involved with the board of GASCO at that time, and I called a bunch of the people that I knew at different institutions at Wellstar, Piedmont, and Emory, because we all have a clinical trial database in our own system, but we don't know what it is in the other systems. I don't know what the clinical trials are at City of Hope and at UCBC and at MCG, Georgia Cancer Center. So how do you find that? And it's very difficult. And I searched clinicaltrials.gov, and I wasn't able to find a clinical trial that fit her. And she ended up progressing and passing away that year. And so fast forward about 6 or 9 months, and there was a board meeting at GASCO. And a lot of the same people that I had talked to, we sort of got together and said, how do we make this better? You know, how do we find clinical trials that are efficacious for our patients? So there was a lot of discussion about a database and a website or some sort of way you could easily access. And it was actually Dr. Nick from UCBC who suggested, why don't we have a person? Why don't we have a position who is in charge of this, who could be a resource for all the researchers, all of the cancer doctors in the state, and for all the patients who have cancer in the state. So the idea of the Clinical Trials Navigator was born, and then we sort of switched the name to Georgia Clinical Trial Finder. And so this is a Georgia core initiative, and Lynn Durham has spent a lot of time working on this. So thank you, Lynn, for everything you've done for the Georgia Core Clinical Trial Finder. But it's a position that is funded by Georgia Core, GASCO, and a grant from Amgen. And this position is system agnostic. This person is not betrothed to any cancer center, but they're only to help all cancer doctors and all cancer patients in our state. And they basically function to help us find clinical trials. This type of program was not known to exist in 2022 when we kind of put this together. I think now there are a lot of companies, especially even centers that have their internal clinical trials finders, but I don't think that there is a system in the country that is doing this that is not part of a system or a company. I have seen a publication from Canada where they have something like this in Canada that started in 2023. So I think we're on the cutting edge of something that could really help our cancer patients. There are multiple benefits from having a clinical trials navigator or a trial finder. Number one is patients have increased access and enrollment in clinical trials that directly benefits the patient. But also it benefits our systems because we have more clinical trial enrollment. And that means we do more research and we have more data. Well, there's also what I call system cross-pollination. So what that means is that if I have a patient and Dr. Nick has a trial at UCBC, I can call him up and say, hey, I've got a patient who fits your trial. Would you see that patient and manage that patient on trial? Or the other way around. So each of our systems will receive referrals for our clinical trials. And then we will also refer for clinical trials to other systems. And I like to say a rising tide lifts all boats. So that means that all of the systems enroll more patients in clinical trials. And there's sort of a tertiary benefit to this, in that if this system is successful and we have significant increases in clinical trials for all of our systems, then Georgia is going to become known nationally as a hotbed for research, which is going to lead to more clinical trials being opened in our state. And therefore, we would be able to enroll even more patients. So it's only 2 years into the first iteration of this project. And so far, there's been 85 referrals, 5 completed consults, and 1 patient enrolled on a lung cancer study. And I did say when this started out that if we just put 1 patient a year or 1 or 2 or 3, we're going to be successful. So I think we're on the way. We have a whole nother year in the first funded 3-year project, and we'll see how it goes. But I would encourage all those who are cancer providers to look into this and use this as a means to find clinical trials. So I wanted to close with 2 more slides, and this is something that is dear to me. Cancer is too close to all of us, all of our families. I think President of Augusta University mentioned that all of us are touched by cancer in some way. I was taking care of a man who was 57 years old with pancreas cancer. He was diagnosed in March of 2024. And his chemotherapy was given. He had liver metastasis, and it worked for a little while. He had some months of some improvement and doing okay. But then after about 6 months, he progressed and his disease got worse. We knew from that next generation sequencing that he had a mutation called the KRAS G12D mutation. It's a very common mutation in pancreas cancer. So we started looking for ways to target that. We knew also that there was another mutation, a very similar mutation called the KRAS G12C mutation, which is sensitive to and a target for a drug called sotorasib. And that is FDA approved for lung cancer with G12C mutation. So a very similar situation. And there's a lot of research into how do you target other KRAS mutations. So we sought out consultation at MD Anderson. I did use the Georgia Core Clinical Trials Finder to look for a clinical trial in Georgia. I was not successful. We did end up going on to some subsequent chemotherapy. And then we had consultation out of our state at Sarah Cannon Research in Nashville. They do a lot of research there as well. And they did have a trial available. However, by the time all of that kind of transpired, he was not able to, he had further organ deterioration, was not able to be treated on that clinical trial. And so he succumbed to the disease. And that was in November of 2024. So he lived about 8 months, which is less than the median survival that is in the literature for pancreas cancer. So we were not successful in treating his cancer, and it's very distressing. And I wish we had more for this patient. You all will know this patient is Mr. Bruce Thompson, who is a Georgia State Senator and Secretary of the State Department of Labor. And he was a wonderful man, just a great leader, really beloved by many, many people. And we didn't have enough for him. And so it's cases like this that really drive the passion that we have for developing clinical trials, developing therapeutics, because the clinical trials we do today will set tomorrow's standard of care. So thank you for your attention. I'll take any questions.
Thank you. You do have a question.
Thank you, Doc. Oh my gosh, interesting. I may have missed this. We've talked a lot about communication. What am I doing with this echoing? Is it, what do I do? Thank you. When we are looking for matches, let's say a blood cancer, we're talking a lot about Georgia. Do we look outside of Georgia too? And will the
Clinical trials.
the computer analysis, it does go outside the state of Georgia for matches outside the United States? What does that look like?
Well, so if a patient is being seen by any practitioner in the state and that practitioner wishes to find a clinical trial within Georgia, then our clinical trials finder will search. And we do have a person, Marquita Iradusu, who is the clinical trials finder. She will look and talk to all the medical centers in the state to try to find a trial. And I have asked her 40 or 50 times, hey, find something for me. So she is very good. She usually gets back to us within about 2 or 3 days with a list of clinical trials. And what we've really said was that we want the physicians to be able to look at the available trials and then call the doctors who run the trial. So just as an example, I have a young man who's 55 right now who has lung cancer. He has something called an ALK mutation, an ALK mutation. It's a not common but known mutation. And there's several drugs against that, and it's a hotbed of research for more drugs for ALK mutation positive lung cancer. So I asked her for a clinical trial, and she found me one at Emory. The problem was he already received the drug that they were researching. So sometimes there are a lot of barriers, and I didn't get into barriers of why people are not enrolled in clinical trials, but a lot of times you get a situation where someone's disease is not exactly right. They don't have the right histology or the right, description of the cancer. Maybe they have too many abnormal organ functions. Maybe there's some other laboratory problem that won't allow them to get in a clinical trial. So, but to answer your question about outside the state, I think we're starting to think about asking some of the surrounding medical centers like Birmingham and some of the ones in Nashville and maybe even in South Carolina. Are we expanding a little bit around our state? I know we're not going to do a national search, right? But yeah. And by the way, I did want everyone to know that I was in touch with Senator and Secretary Bruce Thompson's wife in the last few days. They got her permission to share his story with you. So I want to make sure that was very compliant with privacy protection. So.
I would just request the committee, I know we could have a lot of questions, but we've got a lot of presentations today. So if the committee could find the person you want to ask a question after we're through with this, I'd appreciate it. I know your questions are important, but we've got a long list of folks with a lot of information and very good information, just like we heard there. Thank you very much. I appreciate it. Dr. Cortez is up next.
Good morning. Thank you, Mr. Chairman, and thank you all for being here. I want to first start by welcoming you all to the Georgia Cancer Center. We are very proud of this institution and of what we can do for the population in Georgia. And I want to start my presentation with a little bit of a personal note. I've been in my career, I started my training, and then I spent a total of 27 years at MD Anderson Cancer Center on faculty, where I did a lot of clinical research and had some leadership roles and so on. A very frequent question that I get probably once a week at least is, why did you leave MD Anderson to come to the Georgia Cancer Center in Augusta? Just yesterday, somebody asked me that question. And the answer is very simple. When I was invited to come here, I saw a lot of opportunity. I saw a lot of need. I saw an institution with great aspirations, with great leadership, with great opportunities. And the goal was to try to get us to NCI designation. And I thought that was a very mighty goal, a very complex goal, but a very important one for the community that this institution serves and for the state of Georgia. I also saw challenges. We do have many challenges, and it is not going to be easy. We are going to make it. I'll start with that. But when you deal with cancer, when you deal with research, the challenges are what the patients face. What we face are opportunities to serve, to help, to overcome those challenges, and to help the patients overcome those challenges. Those are our responsibilities and our opportunities. So that's why I want to present to you why the importance of an NCI-designated cancer center, and put it in the context of what we see in Georgia and what the Georgia Cancer Center can do. I'm going to start by just giving a little bit of oversight of what's an overview of what the NCI designation means. Essentially, in simple terms, is this puts together a cancer center where everything that has to do with cancer, the research, the education, the patient care, the prevention, the early diagnosis, the education, the community outreach, all of that is put into one common roof with a common theme where all of these aspects interact with each other, they feed each other to serve the community that is called the catchment area for a cancer center, and you have an impact in that community. So what the NCI is looking for is that there is interactive research programs that feed each other with all of these elements. There are centralized shared resources that facilitate the research by preventing each investigator to having to have their own machines and technologies and all of that, but just centralize everything so that you can provide it to all the investigators. You have strategic planning, so you can look at what are the needs, what are your opportunities, where do you want to go, and how you can assess the impact that you have in the community. You have developmental funding to help your investigators take risks, investigate something new, take challenges so that they can go out and generate some initial data and go for the big grants and the big trials. You have activities that engage the population. You go out there to the community and teach and educate and prevent and diagnose early, and have the opportunity to educate the public in general. And you have also the education activities. You are trying to form the new generation of the researchers, of the cancer care providers, of the community outreach that is going to be the future of cancer care, who are going to be in charge of providing that next step when those of us who are a little bit older are going to be out of the way. And you have the administration and the oversight of those clinical trials that are needed. So all of that is under one roof, and that is an NCI-designated cancer center. There are 73 NCI-designated cancer centers in the United States. There are 3 categories. There are what is called the basic cancer centers. Those are only do research in the laboratory. There are a few institutions like that that are outstanding. Cold Harbor, for example, New York, where the DNA was discovered and so on. That's all they do. Outstanding, but they only do research in the laboratory. There are the clinical cancer centers, which is the entry step for those like us that have a clinical leg and a research leg and the community outreach and all of that. There's 9 of those. And then there's the comprehensive, which is you evolve from the a clinic to the comprehensive when you've acquired your NCI designation and you demonstrated that you've been able to build on top of that and advance it further. We have 57 of those. Our initial step will be to go to a clinical designation. Now, one important thing that is one of the elements that I mentioned at the beginning that caught my attention is that of the 10 largest states by population in the United States, Georgia is the only one that has only one NCI designated cancer center. A very good one at that, Winship, Emory. They do an outstanding job. They are actually a comprehensive cancer center now, but one for our state, our size in population, in area, is clearly not enough. There are even states that are smaller, that are below the 10, that have 2 NCI designated cancer centers. I think this is something that we need to work on. Now, I'm going to show you some statistics, and we've gone through these over different presentations. So I'm going to be brief, but putting them in the context of that NCI designation. First, this is the incidence and the mortality in Georgia from cancer. And as you can see, in both areas, we are above the average for the nation. We get a higher incidence of cancer in the states compared to the average in the United States. And the mortality for cancer is higher in Georgia compared to the United States. The tumors are the same that we see overall. The most common ones are, as you would expect, breast and prostate and lung and colorectal. So the type of tumors that we see is not different. Again, the incidence and the mortality is different. But some of these cancers are important because when you think about, for example, breast and lung and colorectal, these are tumors where you can do early diagnosis and for many instances, even prevention. So when you look at the cancer screening rates in the state of Georgia, I will tell you here in these maps, the lighter the color, the worse the impact of the screening. So white means far fewer women are getting mammograms or individuals getting colonoscopies. And as you can see, there are many areas, and particularly for colonoscopy, where there is a very low rate of colonoscopy. So we are not doing that early diagnosis, which means we're detecting the cancers later when the prognosis is much worse, the treatment is more aggressive, the outcomes are not nearly as good. And you, by the way, spend a lot more money doing that. And you can see that, for example, with colonoscopy, a lot of that low diagnosis is all around this area, which is very close to where we are. And you know, I'll take the opportunity to mention some of the things that we've been doing in outstanding collaboration with Georgia Core, with Phoebe, doing a program to increase the rate of colonoscopy in some of these areas throughout the state. Looking at lung cancer, the smoking rates around the state are very high. Here, the darker is the higher. So look at all these areas where the smoking rates are very high in the state of Georgia. And again, these are all around all our backyard. Here we are, and this is all our neighborhood where we need to do something to prevent that. We also did an analysis. Dr. Moore is one of our former faculty here. Unfortunately, we lost. He moved to another place. But he did an analysis before he left about what's called the hotspots for mortality from cancer in the state of Georgia for some of the most common cancers. So that means that the mortality rate is way higher than expected. And look at the breast and prostate and colorectal and lung. They're all they're large areas of these hotspots, and many of them are surrounding our area. So that tells us that there's a lot of need around where we are, where we could have a significant impact. So NCI defines 6 essential characteristics for an NCI designated cancer center. Of course, it has to be cancer focused, only research related to cancer, only care related to cancer counts. You have to have the physical space where you can do the research, the clinical trials, the clinical care, all of that under one roof. You have to have the organizational capabilities that allow you to put all of these together to do all your activities. You have to have that transdisciplinary collaboration so that the research includes all the aspects that have to do with cancer. You have to have institutional commitment, and this is broadly defined from the state, from the university, from the community, from the health system, et cetera. And then you have to have a center director that oversees all of these activities. The NCI is looking on an emerging center, which is us, for exceptional institutional commitment and community support. They want to see that before anything, to make sure that you have the support of all these entities. You have to have a unique catchment area that is distinct from what is covered by other entities around us. So yes, we have Emory, we have on the other side, we have MUSC, we have University of Florida. But this is an island where we don't have any of those having an impact. And there is high burden. There are a lot of disparities because of the rurality and the insurance and all these things. So we have that opportunity to address all those social determinants of health that contribute to the outcomes in cancer care. You have to provide care to these underserved populations. You have to have enough grants from the NCI and the NIH. We are very fortunate here. We do have we are small, but we do have a good amount of those grants that are required already to start, and then you'll get more. The collaborative research, where you collaborate, you have your investigators working within themselves with others in other departments of the same university. You have to have that community outreach and engagement. So you go out to the community and detect and educate and screen and all of those things, which we do. Your research is meaningful. It really has an impact in the community. You're doing the things that matter the most to the community that you're serving, and you can demonstrate that impact. That you have a significant clinical trial program where at least 10%, but ideally more than 15% of your patients are enrolled in clinical trials. You just saw the statistics for the state, 3.7%. That is clearly not enough. We need to have much more than that, definitely for a designation, and a dynamic pipeline of students and trainees and all of that. So again, putting that all together, you incorporate all of that into one package and you submit so that they can see that you can do all of these activities. All of these brings a lot of benefits, most important to the community, because part of the deal is that you have to have community impact. You really have to demonstrate that you are really helping the community that you serve. It also brings volume, quality, prestige. It attracts patients, it attracts sponsors, it attracts grants, it attracts investigators to recruit them to these reputable places. That's the first place you look when you're looking for a job. If you're in research, if you're in cancer care. It also brings the benefit of research and innovation. That means you're developing those things that eventually become clinical trials elsewhere. You are starting them in your own place. It brings benefits in cancer care. You provide the most outstanding care because of that in multidisciplinary opportunities. These cancer centers have the best outcomes. They have the access to the latest treatments that are available. It also improves the opportunities for training of the workforce, and not only the physicians and the researchers, even the staff that manages the clinical trials, that provides the navigation. All of them get outstanding training within your own place. And it definitely helps in growth, economic growth for the institution, being the healthcare, the university, the community, and the state. What are the features that make us unique and that make me think that we can achieve this? We have our mission, which is to reduce the burden of cancer in Georgia and across the globe through superior care, innovation, and education. That's our mission, and that is a very important place to start. We are the only state-designated cancer center in Georgia. Winship is part of Emory. So we are really the only state designated cancer center that includes all of these elements. We are the only academic cancer center in the CSRA region and beyond. And we are home to the Medical College of Georgia. We actually are under the umbrella of the Medical College of Georgia, which is the fourth largest medical school by enrollment, and that has multiple campuses throughout the state, which is a big plus for us. We have great science in many areas, in immunology, not only within the cancer center, but with the immunology center, which is housed in this same building. Cardiovascular disease, which is an important element of cancer care. Sickle cell, we are the top of the line in sickle cell. Inflammaging here in the university, something that's very important to cancer. We have a very productive research faculty. The amount of grant dollars that our faculty bring per individual is above average for many of the cancer centers that are already designated around us. We're just small, so we don't have as many dollars total, but the dollars per investigator are above average. And we have a newly created School of Public Health, which is also very important in terms of the work that we need to do in the community. And we serve a critical population. Look at the rurality around us. You know these very well. But we serve a very, very highly rural community, which is very important for the work that we can do, that we need to do, where there's also a high percentage of uninsured, high percentage of individuals living in poverty. That gives us, again, not only that opportunity, but also that responsibility to help them well. So I could keep going on, but I realize we have a lot of speakers, but I hope this conveys the message of the importance of having at least one other NCI designated in the state of Georgia, and we will be happy to take the lead on that. So thank you very much.
Thank you. Thank you. Up next, we'll hear from Dr. Vias, oncology workforce shortages.
Thank you, everyone. I thank the committee for giving me this opportunity to follow up on my video testimony from a few months ago and talk about this very important issue. I'm Dr. Harsha Vyas. I practice in Dublin, Georgia. My colleague, Dr. Nick, spoke first about private practices and the challenges we face. I'm like the HBO series, The Last of Us. I am the last of the private practice, fully owned doctor practice in a rural area. That's last time I checked, there's no one else left in the state. So I'm unique at this point in time, and I have 15 years of in the trenches view to tell you what's going on and hopefully reverse this trend. So why does this matter? So Georgia is a rural state. 1 in 3 Georgians live in rural counties, and it is a massive need. About 7 to 8% of the oncologists practice in rural areas, where about almost 20% of the population lives. In the state of Georgia, this oncologist to patient gap is massive, even wider. Local oncology care isn't a luxury, it's a lifeline. I have my dear patient, Spence, sitting in the committee. This may be a good time to share this news. His 5-year scan was clean. I took his permission. So that's the reason why I do what I do. Cancer care is rapidly consolidating in large health systems in urban areas. There's hardly anything left in local rural areas. I can tell you in the last 15 years, I've seen it with my own eyes. And without any further action, rural Georgians will continue to face significant delays in treatment, fragmented care, worse outcomes, and simply no doctors. And if there's no doctors, there's no care. There's no care, people are going to be driving 60, 70 miles, which they're already doing to come to my, where I say I'm in Dublin, I'm in the Manhattan of Middle Georgia, and there are even more rural counties out there. And for them to get to me, if they're doing, 60 miles, if I'm gone, they're going to be driving 100 miles, which is terrible. So, think about gassing that F-150 and driving 100 miles to Atlanta. They're not going to go. So this is a serious issue. What's going on with the rural oncology workforce issue? Well, basically, it's a supply demand issue. We've got an aging oncologist population who are retiring, and we have a pipeline failure. We're just not making enough oncologists. The state of Georgia graduates 7 oncologists, 3 here and 4 in Emory, and we're pushing 11 million people. This is just not the math just doesn't add up. I graduated from Wake Forest University in North Carolina, a state of similar or smaller size, and I have 3 times the number of fellows. They have 6 training programs. We're really behind in this matter. Why do they not move to rural areas? Well, the fellowships are concentrated in metro areas. They rarely have any rural exposure. I've said in my video testimony, I had the opportunity to kind of go to this rural community in North Carolina, and I just loved it. And I said, maybe I should interview and find out what my other options were, and I would not do anything different. And this is something which we really need to change. There's no real mandatory rural oncology rotation in anywhere in the country. So they just never get exposed to going to rural area. And they're just wondering, if I go to this place, I don't have any supporting specialists, what am I going to do? There's a huge student loan burden. If you do 4 years of undergrad, 4 years of med school, 3 years of residency, 3 years of fellowship, you're typically nowadays walking out with $300,000, $400,000, $500,000 in debt. They just don't want to take a risk going to rural areas, starting a practice. And there are some seriously faulty reimbursement patterns on how they pay rural practices. And of course, every fellow I interview says, when are you going to close? If I join you, if you're gone in 4 years, I'm going to be without a job. And he's probably right. That's the problem. Other issues, this is the most common thing I hear about people wanting to move to rural areas. How are the school systems? How close am I to an airport? These are, more systemic issues, which is a problem, but, it is what it is. The other big issue I've alluded to before is the lack of supporting healthcare workforce currently. It is very difficult to find nurses, LPNs, MAs. My cancer center is the place where all of the nurses in the local VOTEC school rotate through, and I end up hiring the best of the best, but still there's a serious supporting cast problem in rural areas. The need, like I've said here, we need to fund and send oncology fellows to rural areas during their training. They've got to go and see what's out there. If they don't see it, they're not going to come. We got to work out some kind of loan forgiveness for these folks for them to incentivize them. We really need to fix how rural areas are being reimbursed. You just can't pay me less than you would pay somebody in an urban area and expect people to move to rural area. They're just not going to do it. And that's the GIPSY index, which has been faulty for years, which can be fixed. Another issue, these are all, now I have to say this is the minority point of view, but if I don't talk about this issue, I'm not going to be honest to what's really going on. We have a real problem with hospital consolidation of oncologists. There is a program called the 340B drug program. It was legislated in 1992. Great program to help out rural and safety net hospitals. It still helps them, but this program has gone way out of control. It is currently in a situation where back in 2010, about $6 billion went into 340B drugs. We're now over $60 billion. It's just hard to believe that many hospital systems came into being in just 16 years. But this basically mandates the manufacturers to give drugs at deep discounts. And of course, the hospital systems can negotiate better reimbursement. And on independent oncology clinic like mine, I don't get any discounts. I have to buy drugs at a average sales price. And I just don't have the ability to negotiate better reimbursement. These guys don't want to talk to me because there's so much of noise by the larger health systems. Like Dr. Vyas from Dublin is not on their number 25th on the list. The margins are shrinking. Patient load is going up. I'm extremely busy. I take care of several family members in the same family. It's just not a situation which can sustain for too long. And we are, of course, competing with healthcare systems, which obviously have major market share. We often, we try to do more with less, but current situation is not sustainable. There are several legislations been put forth, but we absolutely need some 340B guardrails and reform. If the if the 340B dollars are supposed to be for patients, it's got to get to patients. And also, if I'm giving the same care as someone in a hospital outpatient, I need to be paid for the same. That's called site neutral enforcement. There is just no magic or, shocking thing about it. You just have to pay me the same if I have to keep my doors open. And that's just not happened. And it's actually getting worse. Well, again, this is if I don't talk about these guys, then I'm not telling you what's really going on. There's something called as the pharmacy benefit managers. They're middlemen in the healthcare system created by insurance companies. They dictate all sorts of things they shouldn't be dictating: drug access, what can be in the formulary, what I can dispense at my community cancer center. Obviously, there is a major incentive for the pharmacy benefit managers to steer the drugs to their insurer or their owned pharmacies. And as a result, regularly, we would put in for an oral cancer drug. The cancer drug the prescription gets steered. The prescription, we're waiting to find out, delays in treatment, and I can't do anything about it. I have no control. The rebate model obviously is kind of jimmied for them to increase their prices and profits. Just 3 PBMs control 80% of the drug market in the country. That is, if that's not monopoly, I don't know what else is. And they're massively vertically integrated. The PBMs are owned by insurers. It's just what do I call it? A too big to fail system. And a small clinic like me just cannot compete with this scenario. We've done some amazing stuff in Georgia as far as PBM reform, but the problem is the law works only if you complain, and doctors just are not doing it. We just don't have the time to actually get in and make a 3-line complaint. We may be able to do it, but there's just not enough complaints coming in to actually do something about it. We need some serious anti-steering policies, and they need to be reimbursing me exactly how they would be reimbursing their own pharmacies. A person with a lot of expertise is Representative Buddy Carter of the Georgia one. He's worked a lot in this field. He's an expert. He could tell you all the stuff they've done and why there are hardly any independent pharmacies in large parts of Georgia. This has to be addressed. If really we need to, structurally, if you need to do something about somebody wanting to open a new clinic and actually dispense drugs and do something about it. And of course, these are the other top reasons why you're just driving doctors like me into burnout. There's something called as prior authorization. This is basically nothing but a utilization management program utilized by insurance companies. It's anything and everything now needs a pre-auth. We ask for a FDA approved NCCN guideline drugs. There's a pre-authorization. We're waiting for it. And then finally, most of the time they have it approved, but you're looking at 16, 18, days delay before they do that. There's no reason for that. That needs to be addressed. Step therapy. This is a very dangerous game played by payers. They want you to use the drug they want you to use before basically you have to fail the drug they're saying you got to use before you can use the cancer drug the doctor is prescribing. This is just simply, I'm a 3rd-generation physician. My dad would have retired the day he saw something like this. And this is something which is very distressing for physicians, that an insurance company is dictating what drug I should give after going to 16 years of school, but it's happening. And the last time I checked an AMA survey, 92% of the doctors said prior authorizations and step therapy were the #1 source of their stress and the reason why they would retire. There's a gold card law, which was enacted in just this legislative session. I believe this needs robust enforcement. And the payers need to be reimbursing clinics like mine at fair rates to keep the doors open, just like how they would pay a larger health system or whatever larger entity they're negotiating with. The largest payer in my area is just stringing me along. I've talked to them several times. They don't care because I just don't have the clout or ability to do anything about it. So here's the need. We need to keep them accountable. I can't call them to the table. You guys can, and you got to ask them the tough questions. Gold carding rural practices like mine. I'm a quality practice. I've been in the OCM program. I'm on the quality track with Anthem, Blue Cross Blue Shield. There's just no reason for me to, have 5 staff members begging for cancer care treatment approval when there's no reason for it. And of course, a cancer drug needs to be approved in a timeline. And if they don't do it, you got to call them and ask them why. These are some infrastructure barriers kind of unique to rural areas. I really did not know about all of this until I got here a decade and a half ago. There's really some areas where there's not much of internet access. And we've done a lot of work in this thing. We just need to keep pushing along. This would really help when we kind of call our patient and kind of goes into the answering, because they don't, they just don't have the ability to contact us. It's a problem. Telemedicine was a big issue during COVID because of the spotty broadband reach. So we need to keep working on that. This travel times, I don't know what the real solution would be. I've got people traveling long distances. This is causing missed appointments, delayed treatments. It just, it's just unbelievable. People drive like on an average 30 to 50 miles to get to my cancer center. I have a few suggestions right there. I think creating something like a nurse-run hub close to some of these even smaller towns around Dublin, where they could go in, check in, and the nurse can call me, would really reduce the drive they'll have to take. You need to strengthen whatever is left of our rural hospitals. After I've gotten there, about 3 of them have closed in my area. Now they have to come to my town to get blood transfusions. This could have been easily done if there was at least a small critical access rural hospital present in even more rural counties. And there's a need so the average rural patient happens to be poorer than the urban counterpart. There needs to be some kind of grants we can create for these lower socioeconomic rural patients for out-of-pocket expenses. It is really expensive to go through cancer care, and it's really sad to see how not only are you sadly passing away or dying from cancer, and you're actually dying broke. And this is happening all the time. We have to address it. We have to have some kind of a situation where people can apply for grants, and it gets passed on to the patients safely. I have my own not-for-profit, which I've been running for a few years and giving out as many grants as I can, collecting funds, but there needs to be more. The need is massive. Conclusions. So this is a really solvable problem if we choose to act now. Rural Georgia definitely and most certainly deserves equal, affordable, and local access to cancer care. They should not be driving 60, 70 miles for basic cancer care. Every delay, every obstacle can cost a life. Doctors like me, we're certainly committed to serving in our rural communities, but we need the right tools and support, or we're certainly going to be wiped off the map. Thank you for your opportunity, and I'll be glad to answer any questions.
I want to thank you for your informative presentation. I want you to be assured that we are looking at these issues. In fact, I have a few meetings set up at the end of this month on the 340B program. We addressed that last year. The PBM issue that you brought up, we've been fighting for. The gold card we did pass this year. We did some other work. So we're working in this area as a legislature to help you. I'd like to have more conversation with you in the future. I
Sir,
think.
thank you so much for your time.
Yeah,
I
thank
did
you
add
very
a
much.
reference on North Carolina's work they did on the 340B drug program. The state treasurer did a fantastic job looking into how much more the state is paying unnecessarily. I've sent all of that to Morgan as well, but thank you, sir.
Thank you very much. Okay, I tell you what, let's take a 10-minute break. Is that okay? The committee, we'll be back in 10 minutes. I thought you'd like that. If everyone can sit down, we need to get started. We've still got a number of presentations to go. And we've got Dr. or Dean Hess that I'm sure needs to get back to something else besides waiting on us. Quickly, I want to recognize Representative Howard, who came in earlier this morning. Thank you so much for being here. Okay, Dr. Hess.
Thank you very, very much for inviting me to speak. And I'm not an oncologist. I'm only a neurologist. But I do know something about the limits of human working memory and cognition. And I'm so impressed that all of you were able to sit through all those excellent presentations and absorb all that information, because I had trouble keeping up. But our medical students would be proud of you, of how well you're doing. So we have one of the largest medical schools in the country. We're the 13th oldest. Remember, 13th colony, 13th oldest medical school, MCG, founded in 1828. Our bicentennial will be in a few years. You're all invited. We have the fourth largest entering class in the United States of medical schools, and Georgia's a big state. And we started our Savannah campus. So we have a map up there of our regional campuses, and we're all over the state. Those white dots are where we have student rotations. And our campuses, they're not quite the congressional districts or your legislative districts, but our deans divide these up in a back room. And you can, Kush Desai can give you the details how this is determined. Even I don't know. But we have all these campuses. We have a new four-year campus in Savannah. You know, Savannah's growing, and there's 41 students there. It's a four-year campus. And we're doing a residency program with them. One of the recurrent themes in Georgia is if you ask a question in Georgia healthcare about staffing of physicians, numbers of residents, numbers of medical students, we're 40 and below in everything, which isn't good. One is the best. So we are very behind in healthcare professionals. But we're behind in GME, so we're trying to start new residencies. There's Paul Hinchy, the longest surviving, continuously serving CEO in Georgia. And there's Natasha Savage, our GME associate dean, and we're helping them develop an internal medicine program. Because before you can be an oncologist, you got to be an internist. We have a new regional campus in Atlanta. I'm just going to quickly go through these. I was warned last night and lobbied to speak no longer than 10 minutes. So I am from New Jersey, which gives me an advantage. I had an extra cup of coffee, so I'm going to try to make this. We have about 24 students there, not quite, but we'll be there. So we are expanding, big school. And then here's where it all started. Our Southwest Regional Campus was our first campus, our first regional campus begun back in 2008. And I'd like to enter into exhibit Kush Desai up here in his blue Phoebe shirt and MCG Southwest Campus shirt, because he's exactly what we're trying to do. Grew up in Columbus, Georgia, went to MCG, trained at the Southwest Campus. Then he did his residency here in internal medicine. And then along the line, he picked up an interest in colon cancer. I think you've heard from him. So he's an internist who does cancer research, who was born and bred in Columbus, who went to our campus. And now he's also a dean at our Albany campus. So this is what we want to do. So yeah, give him a hand. I'm sure I embarrassed him thoroughly. And then just south of there, we're growing a campus in Thomasville in the Southwest area. And we were down there a few weeks ago. We're going to start putting 6 students there in a few months. And Thomasville is a very advanced hospital system. And we've got to be down there we kind of guarding our southern border there because, you know, these Florida students are coming. I'm nothing against Florida, but we got to train Georgia students, right? And then we have a Northwest Regional campus up in Rome and Dalton. As you can see, we're all over the state. And then we redesign our curriculum. So we have a large medical school and a complex medical school. So we now can graduate students in 3 years. And the first 2 years of medical school, we compressed to 18 months. And our students, though, you know, they get a lot of lectures like you do, but even they like breaks. I'm glad, Chairman, you just gave us a break because I was really worried about our limitations. But you can get a dual degree, you can get a master's, you can get an MBA, you can get an MPH, you can get a research concentration. So we have something for every student. And then thanks to the Georgia legislature, and thank you very much, we have a private-public partnership to do we call Peach State Scholars. So this is our 2024 group. And these are students, and by the way, 95% of our students come from Georgia. That's one of the highest in the country. Mercer is actually 100%. So the Georgia medical schools really take a lot of Georgia students. But these are our students, and they finished medical school in 3 years. They've got to agree to do a residency in Georgia, which is good because then they're going to stay. And then we pay their tuition for every year. Every year we pay their tuition. They got to do service in underserved Georgia, which is almost all of Georgia. So this was an endowment that's now about $50 million, thanks to the state of Georgia and Peach State Health or Centene and other donors. Had a lot of other donors for this program. Now it's a long path to become a cancer doctor. You got to go undergraduate 4 years. We actually have a 3-year program for undergraduates here, but that's unusual. And then you've got to spend 3 to 4 years in medical school. And then GME is 3 to 4 years, and then fellowship training is 1 to 3 years. So by the time you're out, you're in your mid-30s. And it's like my 2 sons are actually going into cancer. They say, all our friends are doing all these wonderful things, and I'm just finally got my first job, So it takes a long time. And we got to support people through this process. I also want to announce Jenny Wren Denmark is here. I had to cut some slides because I was told 10 minutes, but we're also doing a lot with the FQHCs. And the FQHCs are the best secret that no one's heard about in Georgia. I mean, they do a wonderful job. State Net Hospitals are trying to do a GME program with you. So thank you very, very much. So here's our HEMONC fellowship program here. I saw an Anjal. I think he had to get up, leave and see a patient. There's Locke Bryan. And it was mentioned before, I think it's a good comparison to North Carolina and Ohio, which are states about our population. They have many more fellowships because they have many more academic medical centers. In Georgia, Emory and we are the only ones that really train these advanced cancer fellowships. And that's a problem. North Carolina has Wake Forest, Duke, and UNC, and Ohio has 4 academic medical centers, and they're about our size. So we've got to expand these positions. The trouble is, and I could rant and rave about GME all the time, is there's caps, right? Medicare caps the number of positions you have. So the hospital then would have to pay for every position above that, which we do, but there's a limit to how much you can pay for. So we have 3 positions per year. We've get many, many, many applications for these positions. And then Gyn-Onc, we have only 2 fellowships, and say we were the first. Now Emory has a fellowship. This is funded, thankfully, by the Georgia Board for Healthcare Workforce. And there's Bunja Rungaram and Sharad Gamandi who lead this program. But this is key because, again, we just can't replace the number of physicians we need because the limitation of GME slots and fellowship slots. And here's other fellowship programs that we don't have here that Emory has, and there's only 1 of these in the state. So we just don't have enough training programs to produce more. Don't forget, we have 2 academic medical centers in Georgia. North Carolina has 3, Ohio, 4. University of Cincinnati, The Ohio State University, Case Western, and Cleveland Clinic. So we don't have enough. You can't just make an academic medical center overnight. So you got to invest in the ones you have to produce more positions. This is data kind of hard to get, but all I can say is when we're trying to hire hematologist oncologists and radiation oncologists, Dr. Higgins, we were talking last night at dinner, they are really, really hard for us to find them. Very, very competitive, a national shortage. So we're competing with other centers. As an academic medical center, you often can't offer the highest salaries because your payer mix is just different, right? So it's difficult. So very shortage in all these areas and limited training opportunities throughout the country. There's a national shortage of this, a state shortage. And we've got to produce more doctors. We've got to have more GME slots, internal medicine, OBGYN. You've got to get the whole pipeline built up. And so more GME slots will then allow us to have more fellowship slots. And here's the oncology workforce. I won't go through this because I was told I would finish in 10 minutes, and I did. Did I not finish in 10 minutes? Look at that. All right. Maybe happy to ask a question if there is one.
Well, I want to thank you. We're sort of holding the questions to the end.
Okay.
I don't know how your schedule is.
I'll try to stick around.
I'd appreciate that. Thank you very much. Okay, and thank you, Dean. We really appreciate that. Up next is the oncology medical provider recruitment from I don't know. Is Denise, are you a physician? You are not. Okay. Yeah.
Okay. Oh, he said, I can't walk very far because then I won't be on camera. Well, I appreciate the opportunity to come and speak with you guys about recruitment and retention. And I'm really going to focus on the first part. But first of all, we've talked about physicians a lot, but one of our speakers alluded to the fact that it's not just physicians, there's a team around them. And so I wanted you to broaden your thoughts as you're thinking about solutions, because it's not just the doctors. We need to have radiologists, oncologists, we have to have pathologists, we have to have genetic counselors, we have to have nurses, we have to have social workers, palliative care specialists. So it's not just about the physician. And so when we think about this, we can put a physician out there, but if they don't have the support group around them, they can't practice optimally. So when I look at this, for those of you who know me, that the statewide AHEC is all about creating the workforce for Georgia across the state. We focus a lot in primary care, but in rural areas, it's not just primary care, right? It's everything. And so when we look at that, we think in terms of games, if you will, not to be light about this, but there's a long game. What it's going to take for the next 15 to 20 years to get us where we want to be? What do we need to do now? There's that middle game about what would give us some results pretty quickly, but not tomorrow. And then there's the short game about what is the low-hanging fruit that we can grab right now. So when you talk about the short game, that's retention. When I was looking at the data on oncology, one of the things that struck me is that 47% of oncologists report being burned out. 47%. We also looked at the fact that there's 10%, less than 10% in rural areas. And then over 24% are over the age of 64. So there's a lot of stuff happening short term. How do we keep people in the pipeline who are already there? And there are some things that have been put out in the literature about things that we need to look at: flexible work schedules, competitive compensation, professional development, continuing education, mentorship programs, because one of the things we have found is that when you are guiding someone behind you, and I was just talking with Chris about this, it regenerates and rejuvenates you. And so keeping people engaged is an important piece. And then marketing, helping with the marketing to get the staff that we need to support these hubs. So that's the short game. That's your low-hanging fruit. The medium game, and that's kind of what Dr. Hess was talking about, is these training. It is not something that you can get somebody tomorrow. It's a long-term investment in that pipeline, particularly depending on when you start. So if you're starting with those people already in medical school, how do we get them to choose to go into internal medicine and then into hematology, oncology? How do we do that? That's a mid-game kind of thing, creating those incentives and those strategies. But what I'm really going to talk about is the long game. And that's because one of the things we know is that kids today have a lot of career options that weren't available in the past. And if you go and you talk to an 8-year-old in Georgia and you say, what health career interests you? They're either going to say doctor, nurse, or dentist. They don't know the rest of them. So one of the things that you have is the health careers manual that I had put on your desk. And this is just out. It just came out last week. And we do this every 3 years. It's available online, but it has every health career program offered in Georgia. And it has what you need to do to go to school. It has how much money you can make. It has pages and pages of financial aid information. And at the very front of it, we have a professional spotlight. And Dr. Kiker happens to be it, which was just very much coincidental. But this is something that is an example of a recruitment piece. Now, like I said, this just came out. And I was looking through it. We don't spotlight anything in oncology. But that's the kind of things that when you're looking at the long game, what kind of materials need to be developed? What kind of resources need to be developed to make people aware of these careers. Because what we know with youth is that we've got to get to them early so that they can be in the right trajectory and they can be committed to something. There is literature that suggests that minority students make career decisions in the 4th grade. Now think about that. If we really want to change the complexion of our workforce, we've got to get to kids even earlier. But then also, how do you sell cancer care? I mean, talk about Debbie Downer in a high school. So we've got to figure out how to make this exciting, right? And so one of the things is that we have to focus on engaging programs that really allow students to understand the possibilities in the cancer workforce. Hands-on workshops are the best. You know, this experiential learning that you hear about, people doing things with their hands, they understand it better and they get more engaged. Local hospitals are amazing as shadowing, having students shadow because they need to see what these careers can be. You've got to plant something inside people. When I say kids, I'm also talking about kids in college because they need to know what their options are. People don't understand the array of potential careers available. Mentorship programs specific to oncology are going to be very important so that even if you have a student at the University of Georgia who's a freshman who gets paired with somebody in the Cancer Institute here, so that you have that mentoring relationship, so you can see potential future, those are going to be critical, but how do we support that? Distance technology makes a lot of this easier, but it's got to be intentional. Storytelling, you know, one of the things that we've learned when we recruit students is the storytellers and learning to capture that. One of the things as I was looking at this thinking, we need to capture the stories of the providers and the facilities. And I'm going to talk about that in a minute. And then social media. I mean, Lord knows I have 2 boys and I hate social media. I have a sign in my dining room that says, do not think about bringing your phone to my table. And they know I'm serious. But it's a fact of the world now. And this generation, we have got to learn how they learn and what engages them and then move with them. There are some programs that I looked across the country, and I'm not going to read all these to you, but you know, many states have looked at these about how you get students interested in health careers, and there's some commonalities. And you have these, so I'm going to let y'all read them. But one of the things that I found is that probably 80% of the programs related to oncology really focus on experiences in research. Very few focus on the clinical careers. And that's going to be something we're going to need to address. And like I said, there are several in here. These programs tend to be long-term. And when I say that, they range from 2 to 8 weeks. Most of them are residential. Almost all of them pay a stipend. So those are important things to think about from the AHEC world and our general health career programs. What we have learned is that students who come through our intensive programs, which we define as 20 plus hours, 72% actually matriculate into a health profession. That's astounding. So when you think about the investment of time, it pays off. If we have students in a captured setting, we got to give them those environments. The Ohio State University, since Dr. Hess mentioned that, I have them in there too. But these are mostly, again, research, and they focus on high school students. Some of them have early college. There are some things in Georgia, not many. Emory has a summer scholars research program. It's 6 weeks, and it's really about research. Here at the Medical College, we have the summer research experiences, which again, look at cancer research and career exploration. It's through our cancer center. And it's 6 weeks, and students learn key principles of biology, but also look at career paths, not just in PhD, but in clinical healthcare. And then there's our STAR program, which is a broader program, just trying to facilitate interest in research. One of the things that we do in the AHEC is a video site. Now, this doesn't sound very exciting to all of y'all, but I put these up here because A, there's nothing on here about oncology. But these are used in classrooms across the state, actually in the country too. Wisconsin loves our site for some reason. But in the last quarter, we had 2,925 hits, people watching videos. A hit represents a classroom. Okay, so, and these are from Clinch County, all these counties in Georgia. So that number is the number of people who played it to a group. So that group could have been 3 students, it could have been 32 students. So when I say that to say this is a potential vehicle, and I will make a commitment to you, and then Dr. Cortez, I'm going to be calling you. We could have some videos uploaded within a month, just looking at the cancer center and as a facility, because we have facility tours and then we have professions work with us and tell us kind of who you want, and we can get more things out there. And that's cheap. I mean, really cheap. But that's an idea. And the other thing is the kind of things like this, where we can create resources that can be used, that students can go to online. It doesn't have to be a print publication, but really focusing on the careers in cancer care, whether it's research, whether it's clinical, and then we have the distribution system to get it out there. So those are some things that I would put out there to you, kind of in summary. Stipends are important for these long-term programs, 2 to 8 weeks. The multidisciplinary focus is important because not all students can be doctors. Not all students want to be doctors, but they need to know that there's something out there in healthcare for everyone. Marketing. How do we make this something people want to do? Program cost, housing, faculty, materials. They're not that much. I mean, these are relatively inexpensive, but our academic institutions are pretty strapped for these kinds of funds. We need them to be intensive. It can't just be a one touch. It needs to be something where you engage people for somewhat of an extended period and then put them in a pipeline so they keep getting touched across that pipeline. And we need to really, I think, in Georgia, focus on the clinical careers and make that the hook, and then the research underpin that. So that's my comments for you, and I'm happy to, I'll be here if you have other questions.
Thank you, Denise. Thank you. Okay, up next, Technical Education Opportunities by Nikki Gilbert.
Morning, everyone. My name is Nikki Gilbert, and I'm with the Technical College System of Georgia. Throughout my presentation, I may refer to the system as TCSG. Is that better? I am one of 2 of the healthcare program managers, and before I talk about some of the opportunities, the healthcare programs that we offer through our colleges, I'd like to talk about the program that was implemented that developed both of the healthcare managers. So in 2022, in December, the Georgia Healthcare Workforce Commission published a report identifying challenges to meet our workforce demands. In that report, they outlined these 5 concerns. Actually, you just heard some of them. Some of them were attracting faculty, looking for seats in our programs and training opportunities, some regulations surrounding full-time and part-time faculty as well, then having access to programs depending on where they're located, and then having training space to meet the clinical and competency experiences. Also within the report, the commission outlined 3 areas of improvement to focus on. These are maximizing the existing workplace, optimizing our healthcare education system, and then attracting new workers. The report also outlined a healthcare incubator program, which is designed to meet that demand by working specifically with educational institutions and stakeholders. So under that program, you can see some of the initiatives that are represented. I'm going to summarize it by saying that we look at strategic initiatives that meet specific needs. That could be within a region, it could be within a local service areas within the technical colleges as well. We develop customized training programs. We also develop new academic programs. So when we relate that to today's discussion, a little bit of data that I wanted to go over. So the Department of Public Health has outlined cancer as Georgia's second leading cause of death. When you think about our workforce shortages, we know that that directly impacts outcomes and access. When we look at TCSG's role, then how do we prepare for that care access? We have 22 colleges within our system with over 50 healthcare programs. Our focus for our programs are practical, clinically based, and they are to graduate students who are work ready. We leverage this by attaining strong partnerships with our community partners, but also making sure we have advisory committees who help to assist with curriculum design. Taking a look at some of our programs that we offer that are directly related to cancer care, we've outlined some associate degrees and also certificates that we offer. Note that certificates can be completed within 1 semester, getting them out into the workforce pretty quickly. When you see the chart and you review the direct versus indirect, please know that that represents that it is a potential care access to cancer. So they may not have direct patient care, but it is a potential access. So how does this impact Georgia? Well, our graduates fill essential roles once they graduate. Our programs are designed with our advisory committee members, industry, accreditation recommendations and standards. And we also look for nonprofits and publics to sit on these committees to help design our programs. So to sustain and grow, we have to attract new talent. So some of the ways that we do that is we do outreach. On the slide, it highlights high school students, but I wanted to share that we do that as far as middle school students as well. At Augusta Tech this Saturday, they are hosting a healthcare exploratory program camp so that students can come through and go through their programs and do hands-on activities to learn more about healthcare opportunities. We also look at non-traditional adults, making sure that we offer programs for working adults and those who are in rural areas. We have a multitude of scholarships and tuition assistance programs, specifically those that are referencing high demand, high wage careers, such as radiology and nursing. We also outline career pathways for entry level so that we have stackable credentials so that, for instance, a student can come in as a phlebotomist and then progress on to a medical laboratory technician. So how do we optimize and maximize our workforce? Well, one, we develop programs that are as flexible and accessible as possible. We look at developing accelerated programs like our accelerated nurse aid, accelerated phlebotomy. We do outline distance learning programs and hybrid programs. We partner with many of you in this room as clinical partners and also resource organizations to help our students reduce barriers to this education access. Another area that we focus on is upskilling opportunities. As I was preparing for this presentation, I realized that we currently don't have any specialized certification training in oncology. So how do we do that? How do we partner with you all? How do we get the information on what you need to get oncology nurses, to get oncology medical assistants and data specialists? So as you're thinking about all of these resources and the programs that we offer, we would like for you to consider how we can collaborate and work together to take this 5-star path forward, looking at new programs, joint ventures, training, expanding clinical opportunities for current programs, and also specialization in cancer care. I will be here later today if you have any questions. Thank you so much.
Thank you. Thank you, Nikki. Okay, up next, we have Lynette Rhodes with DCH Medicaid reimbursement rates for oncology.
Hi, good morning. My name is Lynette Rhodes. I am the Chief Health Policy Officer with the Georgia Department of Community Health. For those of you who are not familiar with DCH, we administer the Medicaid and Peach Care for Kids programs in the state of Georgia. We currently have a combined budget of approximately $20 billion annually. I believe that we are the second largest budget right behind the Department of Education. So want to talk a little bit about Medicaid reimbursement and how we pay providers as well as some of our vendors. I'm sure most of you are aware that the Medicaid program is a jointly funded program that's funded by federal dollars and by state dollars. Currently, the federal government pays approximately 66% of our bill. So for all of those claims that we pay for Medicaid and Peach Care for Kids services, the federal government actually covers the majority of the cost. The remaining portion comes from state appropriations. And a lot of people don't understand exactly how that works. So each year during the legislative session, the General Assembly will identify a particular amount of money that will be allocated to the Department of Community Health for the Medicaid and Peach Care for Kids budgets. And some of that is determined based upon the percentage that we will receive from the federal government, which changes every year. The federal government actually does an annual calculation to determine how much money each state will get, and it varies from state to state based upon per capita income. And so it varies again, that impacts the amount that we will receive. We are the payer of last resort, which means that if there is another legally responsible party, the expectation is that that particular party or entity will cover those expenses. Here, I just have some high-level information for you on our children's health insurance program. Here in Georgia, we have brand named that the Peach Care for Kids program, and it serves children up through 18 years of age. So we provide Medicaid through two service delivery models. One is called fee-for-service and the other is called managed care. And here is the difference between the two. When we speak of fee-for-service, that means we have a provider that renders a particular service and that provider is paid for that service. Versus the managed care model, which requires us to pay a managed care entity a per member per month fee to manage the care of our members. And so it doesn't matter if that member utilizes services or not. That entity will receive a fee, a capitated fee each month. We currently serve approximately 2.1 million members from the state of Georgia. So overall, approximately 75% of our membership receives care through that managed care model where we're paying a capitation payment. We have 3 care management organizations today. They are AmeriGroup, CareSource, and Peach State Health Plan. If you look here, I've identified for you the mandatory services that we must provide per federal regulations versus those services that are considered optional. And these are important to know, particularly in regards to this discussion as it relates to accessing services for cancer treatments. So an individual could get services through the inpatient setting, laboratories, x-rays, physician services, nurse practitioner services, nurse midwife services. So all of these are available and they are mandatory services that we must cover. And then in that final column to the right, those are the optional services. And you may be surprised to see prescription drugs as optional, but we do provide prescription services here in the state of Georgia in our Medicaid program. In terms of the scope of oncology-related services, I thought it would be good to just list those here. So it's very vast in the Medicaid space. You have everything from imaging, which are your typical MRIs, CT scans, ultrasounds, to biomarker testing, which is relatively new in the state of Georgia and the Medicaid space. We do quite a few screening tests, durable medical equipment, pharmacy benefit, and of course, clinical trials, which we've heard quite a bit about this morning. When we talk about the preventive health services, which is what we also cover, we have our early and periodic screenings for children ages 0 to 21. Again, developmental histories, laboratory procedures, and then the same or similar for adults. So we do provide one adult preventive visit for members ages 21 and older. And then again, beyond that, 10 office visits annually per calendar year. We also cover breast cancer screenings, prostate screenings, cervical cancer screenings, colorectal cancer screenings, as well as several other types of screening services. Here is where we have provided a little bit of information about some of our reimbursements. And I want to spend just a moment here to talk about how do we get to these rates and what do we have to do in order to adjust or change them. Generally, reimburse based upon 80% of Medicare's reimbursement rate. So Medicare will have a standard rate. We'll look at those rates, the codes that they cover, and then typically we'll reimburse at 80% of whatever that rate is with Medicare. On occasion, we are directed through appropriations to increase at a higher rate. And when that happens, we'll get a directive through the Appropriations Act that says you are to reimburse these particular codes at 100% of the Medicare rate. And so when that happens, we will make those adjustments. But again, that's based upon the fact that we have received appropriations and additional funding in order to increase those rates. So if you look here, I've given you just a few screening and diagnostic codes for mammogram services. And as you can see, it varies depending upon the modifier and how those codes are billed. So it's not necessarily just a one size fits all. If you look at the very first row, there you'll see an MRI, and that's a unilateral breast exam or screen rather. And you'll see one rate at $218.39. And then below that, you'll see $63.01 with a code that says 26. So that's a modifier, which means that's only the professional component. So if the provider only bills the professional component, they only get paid the $63.01. So this goes deep into coding and how providers actually bill for services. And so providers do have to have an understanding of what services they're providing and how they're actually submitting their claims to the Department for Reimbursement, because that dictates how they are paid. Versus if you look here at that last dollar amount, $150.88, that's a technical component. So that means if you bill a specific code, which indicates that you only provided the technical component, which is basically operating the equipment, not reviewing the actual screening, then that's the amount that you will get reimbursed. So it is very critical that providers and their billing agencies, because most providers do utilize some type of billing entity to submit their claims, it's important that they clearly identify what services they're providing and which codes should be utilized for reimbursement purposes. If you look here, we've provided some of our reimbursement rates for colorectal cancer screening test. And again, those are listed here. The 4 codes are to the left, and these are not all inclusive. I do want to be clear with this audience that there are many more codes that are available that can be billed. This is just a representative, a small sample. But as you can see here, these are the reimbursement rates. And again, these would represent approximately 80% of what Medicare would cover, or it's a comparison to what our neighboring states would cover in this particular region. There was some discussion earlier, I know, about formularies and PBMs. And so we do contract with PBMs in the Medicaid space. When we reimburse our PBMs, we reimburse for two components, one being the drug and the second being the dispensing fee. So there are two components that are included in reimbursement rates for PBMs. And over the past couple of years, as it relates to independent pharmacies, I know we had a speaker earlier that spoke to independent pharmacies. Over the past few years, we have increased the dispensing fee for independent pharmacies. And these types of requests come to us, again, through the legislature, through the General Assembly, through various advocacy groups. A lot of times, the associations, the provider associations, the trade associations will make those requests to us. And as long as we're able to receive the appropriations and the funding needed, then we can make those increased reimbursement rates. But here we've listed all of the types of prescription drugs that we cover through our PBM. These change every quarter. That is important to note. And they change based upon the rebates that are offered for those particular drugs. And that applies in the fee-for-service space as well in the managed care space. I would like to share with this group that going forward, we are preparing to develop a statewide formulary that will be dictated by the state of Georgia's Department of Community Health. So today, if you're a provider and you operate in managed care and fee-for-service, you are having the joy and privilege of managing to 4 different PBMs that change every single quarter. And again, those are based upon rebates. So the plan going forward is to streamline that process and to have one single formulary. So that way that will eliminate the need to manage to 4 or more. And it will allow for some consistency and flexibility for providers. So as you can see here, prescription drugs are broad: skin cancer, prostate cancer, ovarian cancer, breast cancer, all different types of cancer drugs and treatments are provided in the Medicaid space. So here we've just listed again some of those drugs. I'll take anybody to lunch who can pronounce every single one of them. But this is just, again, just a sample of the types of drugs that we cover on our formulary. So that's very high level, but I think the key takeaway is really understanding the reimbursement mechanism. We do not change our reimbursement based upon regions. Because I think the question that we're being asked today is reimbursement different in rural areas of the state? And the answer to that is no. Our reimbursement rates are consistent statewide across the board. So we do not make adjustments based upon regions. It is very rare when that will occur. We have discussed that issue internally at the department and talked about moving in that direction. But again, that requires appropriations and additional funding in order to be able to make those changes based upon certain regions of the state where there may be a shortage of providers. We've talked about that at a good bit today. And so that's what we would need to do. So I'll be here later on if there are any questions or concerns regarding reimbursement.
Thank you, Lynette. Appreciate it. We're moving ahead on our schedule very, very well. We'll have some time at the end of this. I know that I've sort of held the questions back, and I apologize, but sometimes it's hard to gauge how much we're going to hear in the schedule. So we've got one more speaker. That's Dr. Doug Graham on childhood cancer treatment in Georgia.
Thank you, Chairman Hawkins and members of the House Study Committee for allowing us to have a little bit of time today to talk about pediatric cancer as well. I am the chief of the Aflac Cancer and Blood Disorder Center at Children's Healthcare of Atlanta, and also we are the pediatric arm of the Winship Cancer Institute. So just to give you a brief overview of pediatric cancer, it is the leading cause of death due to disease among children ages 1 through 14 and adolescents ages 15 to 19. Even though today's talk, I'm going to be speaking about children and adolescents up to 19, many pediatric cancer centers, including Children's Healthcare of Atlanta, actually care for patients all the way up to age 21 who have cancer. So an estimated 1 in 264 children and adolescents will be diagnosed with cancer before the age of 20. And then if you look nationally, approximately 15,000 children and adolescents are diagnosed in cancer a year. The cure rates have increased dramatically over the last decades, and now we're an overall cure rate of about 80% for all childhood cancer. But that still leaves about 20% of patients every year who will die from disease. And of course, our goal is to be able to address therapeutic options for this 20% as well. So in 2025, within the state of Georgia, about 650 children and adolescents will be diagnosed with cancer. So now if we look nationally at cancer incidence and have Georgia relative to the national incidence, you can see that 18.45 per 100,000 in 0 to 19 years. And Georgia just slightly less than that, 17.75. And the darker on the US chart is the higher incidence. And again, this is ages 0 to 19. And as a reminder, if you look at all ages, which include adult cancers as well, the US incidence is 436. And at Georgia, we're higher than the US incidence of 472. So if we drill down in pediatric cancer, children and adolescents to the county level, we can see that there are some counties that are slightly higher than the average and a couple of counties that are slightly lower. So some of the counties that are slightly higher include Mitchell, Tift, and Cherokee, and Bibb and Rockdale are two of the counties that have slightly lower incidence. It is hard to say though, even though the incidence is higher in some of the counties, they're not reaching the level to call this a cancer cluster because the number of pediatric cancers are relatively small across the state, including in these counties. However, if we compare this to data that we have seen in previous meetings, if we look at county level for all of cancer, including adult cancer, there are some areas in which have higher incidence of adult cancer across the state. And of interest, those areas do not align with higher incidence of pediatric cancer. Now, if we look at rural versus non-rural for pediatric cancer, and this is the incident rate per 100,000 children, it's relatively equivalent between rural and non-rural, and also the male to female distribution. There is a higher rate, a trend towards a higher rate in females of 19.7 to 17.5, but given the low numbers of patients, this is actually not statistically significant. And this compares to the incident rate in adults, so much higher incidence of cancer in adults than in children. So 538 and 537 for males, 438 to 433 in females. So you can see that there's a higher incidence of cancer in males versus females when we include adult cancer across the state. So of the 653 children that are diagnosed with cancer, how is that distributed across the state? And I can say that we have a network of pediatric cancer centers across the state that care for these children. Nationally, there are about 220 centers that care for children with cancer, and our patients primarily go to one of 5 centers. I'm including Chattanooga in the top because we have a number of patients that go to Erlanger, about 30 patients that are Georgia residents that go across to Chattanooga for their care. But within Children's Healthcare of Atlanta, of the 653, last year we cared for 467 of those patients, and then the remainder are spread across Macon and Augusta and Savannah. One thing I'll say about pediatric cancer in particular is that we're extremely collaborative We have good partnerships across the state and all of these centers, and we work well to find the best care. If different types of care or clinical trials are available for one of the centers, we work very collaboratively to make sure the patients are getting the best care possible. So these are the counties that for which Children's Healthcare of Atlanta saw new cancer patients in 2024. So you can see that it's spread across the state, 79 of the 159 counties, 77 of the 159 counties. And then in addition, we took care of a number of patients across the state, across the United States, with 256 out-of-state patients. One of the things that I'll say nationally is that our center now has more than 130 faculty at Children's Healthcare of Atlanta that just care for children with cancer and blood disease, making us one of the largest treatment centers in the country. And by volume, probably in the top 2 or 3 in the country every year in terms of cancer volume patients that we care for. Our goal is to be not only primarily caring for the kids in the state of Georgia, but to be the major referral center for the Southeast. So we continue to look for ways to branch out and reach other centers that need elevated care, relapse or refractory care, or high technology access or new medications and new clinical trial access across the Southeast. We hope that no child from any other state in the Southeast would fly over Atlanta to go to Philadelphia or Seattle or Cincinnati or Boston, but they would stay in the Southeast. So we're very excited that last year we moved into a new hospital. This is the Arthur M. Blank Hospital in Atlanta. It has 444 pediatric beds. Pediatric cancer and blood disease is a very large footprint, the largest division, the largest center within the hospital with 98 of the 444 beds. And this includes 26 bone marrow transplant beds. We are equipped with Child Life and Family Lounge. We have teachers that work within the hospital. In addition, you can see to the right-hand side of that, the building that holds our faculty offices and our outpatient clinic for the Aflac Cancer and Blood Disorder Center. So we have 80 clinic rooms within that building as well. And so it's contiguous. If patients need to be admitted from the clinic, they can just roll right down the hall into the inpatient service. The other thing I would say is that there is an emphasis on innovation within the hospital. And in particular, we have emphasized technologies such as cellular therapy. So for the first time, we have the ability to manufacture cell products to be used for infusion in patients with 4 GMP rooms that are there. In the past, we've had to partner with other academic centers or pharmaceutical companies, but now we're one of the few children's hospitals in the country that can manufacture cells for infusion right within the walls of the hospital. So clinical trials are the way that we deliver best care for children with cancer. We have over 200 clinical trials that are open to patients in the hospital, including 30 investigator-initiated trials where we've come up with the idea for the clinical trials. We are also one of the 20 phase 1 centers, the Children's Oncology Group, and we participate in a number of consortiums, including one of 16 centers in the Pediatric Brain Tumor Consortium. And a number of other consortium in which we are members are shown as well. I did mention the GMP rooms. This is, as I said, an exciting step forward for us to be able to produce products such as CAR T cells right within the hospital and to come up with innovation with some of the next generation of therapy. This was just given FDA approval to officially open in June of this year. So as we look at cancer incidence at a national level in children's 1 to 14 years, we often ask is there an increase in childhood cancer? And if we look closely, there is actually in 1 to 14 a slight increase that occurred between 1975 and 2015, but we've seen a slow decline from 2015 to 2021. The type of cancers that we see in children are very different from the way that we see prevalence of cancer in adults, with leukemia being the most common type of cancer in children and brain tumors being the second most common. So together, they make up more than half of the pediatric cancer patients. And then if we look at adolescents, there has been actually a slight increase over the last decade with increases in lymphoid leukemia, non-Hodgkin's lymphoma, as well as some brain tumors. There's also been an increase in thyroid cancer, but it started to stabilize within the last few years. We don't know exactly why there is a slight increase in adolescents, but we're continuing to track and monitor this over time. Within this group of patients, the most common type of cancer is the brain tumor, then followed by leukemia and lymphoma. So this shows the top 5 leading causes of cancer incidence in children and adolescents. And again, brain tumors and leukemia are number 1 and number 2 for both of these categories. And then in children, it's also followed by pediatric specific tumors such as neuroblastoma, as well as some soft tissue sarcomas. In adolescents, after leukemia, lymphoma, and brain tumors, germ cell tumors and thyroid cancer round off the top 5. And then if we move to cancer deaths, the leading cause of cancer death in children right now, 0 to 14, is brain tumor, followed by leukemia. And then in adolescents, it's just flipped, with the leading cause of death being leukemia, followed by brain tumors. So oftentimes also the question that we get as a pediatric oncologist is, why did my child develop cancer? And in most cases, we don't know the answer. We have good treatment plans for how to move forward, but it's difficult to tell families at the time of diagnosis exactly why their specific child developed cancer. But we do know that there are some risk factors for developing childhood cancer. And so this is the red bars, they are lined up with the different diseases that show increased risk of developing childhood cancer. And so that we know that genetics can play a role. Genetic syndromes, increased maternal age, structural birth defects can be correlated with a higher incidence of childhood cancer. And then there are exposures that also can contribute to incidence of childhood cancer, including air pollution, ionizing radiation, and pesticides for certain types of cancer. And interestingly, there are some things that can decrease the risk of cancer, including breastfeeding and maternal vitamin use. In a previous meeting, we've heard a little bit about the effect of obesity on adult cancer. I will say also that obesity is an important factor in our ability to successfully treat children with cancer. So both event-free survival and overall survival, and event-free survival takes into account things like relapse as well in calculating that number versus overall survival. But both event-free survival and overall survival are worse for obese children compared to children of normal weight. So they just don't respond as well to the treatments that we provide. And this is especially true for children with leukemia and for brain tumors. But in addition, children who are obese have an increased risk of developing cancer as adults. And you can see that the effect is slightly higher among males than females. And they also have an increased risk of mortality after cancer diagnosis as adults. And this is slightly higher amongst females compared to males. So another component, I mentioned genetics playing a component of a higher risk for childhood cancer. We have understood in the last decade or so that certain genes can make you a higher risk of developing cancer predisposition genes. And we've understood that over the last decade as we have started to sequence all the cancer genes within a cancer cell, and then all the genes within a normal cell, and find out what genes might be turned on in the cancer cell for which we can use precision medicine and we can match up specific drugs. But we also understand that in normal cells, there are genetic mutations that can occur that can make you at a much higher risk for developing cancer. So we have developed, as part of our precision medicine program, a cancer predisposition clinic. And over time, we have understood, and as a national group working with other centers, have understood that many genes can make you, can contribute to a higher risk of developing cancer in children. So we've developed right now an understanding of about 50 different types of genes that can contribute to a higher risk of cancer incidence. And of those, this contributes to about 10 to 15% of all the children that develop cancer have this genetic predisposition to develop cancer. And so what we have found is that if we now look by sequencing at patients that are newly diagnosed, we might discover a gene such as the TP53 gene that can be present in a 3-year-old with leukemia. And that's not only relevant to that child with leukemia because they may develop subsequent cancers or it may modify the treatment that we have, but it also becomes relevant to everybody in the family because now this is a genetically transmitted gene that increases the risk of leukemia. So if we look at everybody else in the family, and in this particular patient, there were 2 healthy siblings and then 2 adults that we looked at their genetic profile. And what we found is that the gene was present in a sibling and in the mother. And so over time, this 33-year-old mother within 2 years and with the identification of the gene had increased surveillance for specific types of cancers, including breast cancer. And the mother did develop breast cancer, and that was predicted at being at higher risk because of the presence of this gene. But also, it's very relevant for this 10-year-old sibling, because now this 10-year-old sibling has cancer surveillance that will occur at this young age. So typically in pediatric cancers, we don't routinely have surveillance for pediatric cancers, but specifically for the patients who have genetic predisposition, we do. And we have learned over the last decade by doing this, that this improves outcomes. So this is just showing you a study of having surveillance or not surveilling siblings of patients that have cancer and how we can detect early and provide better care for patients in which we have surveillance for children that have a genetic predisposition for cancer. The other area I want to talk a little bit about, a special population, is this group of patients that are our adolescent and young adult population. And this is a group of patients between the ages of 15 and 39. So it crosses pediatric and adult cancer. So whereas we've reduced cancer mortality in children 1 to 14, we haven't seen quite this reduction in our adolescent patients. And the decrease in adolescents and young adults is due to the cancer being, the biology being a little different, not having as many clinical trials that are open, treatment protocols are slightly different, and sometimes not having the adherence to treatment that you would have for younger patients. We also know that socioeconomic factors play a role in the decreased outcome that we're seeing in adolescents and young adults, including the high cost and the gap that incurs in insurance coverage, that Medicaid lost at 18 and private insurance drop off at 26. So we know that these factors can contribute to a less than desirable outcome for patients that fall within this range. And we are working to be able to partner with our medical colleagues at Emory Winship to specifically have a program that addresses the best care possible for patients in this age range of 15 to 39. Also want to just mention how insurance impacts outcome in pediatric cancer. So this is a probability of survival, and it is looking at survival ranging from 70% to 100%. And you can see that patients with private insurance at the time of diagnosis, their survival at 5 years is close to 90%, 85 to 90%. In patients that have continuous Medicaid, that drops to about 80%. And so the insurance is good for the continuous Medicaid patients, but there may be other factors that contribute, such as access to care or transportation, that could decrease the survival opportunity for these patients. And in patients with newly gained Medicaid, it's even lower, and that's at 70%. And we hypothesize that this is because of delay in getting to care, a delay in making the diagnosis and getting the care started in an appropriate time frame. I also mentioned that we have increased survival significantly to 80% overall cure rate, but many of the patients that we cure have late effects. So more than 2/3 of the patients, as you can see, will have hearing loss or endocrine defects, and they can have cardiac issues, neurocognitive impairment, liver and kidney issues. About 18% of them can have a secondary cancer that can occur. So whereas we want to continue to target a curative opportunity for all patients, including this remainder of the 20% of pediatric cancers, we also want to look for less toxic therapies that are sort of the second generation of treatments that are maybe not always your standard chemotherapies, but involve cellular therapy and precision medicine and activating the immune system that would potentially have less harmful long-term effects. We lose a lot of our care as we look at patients that transition from pediatric to adult care. we have found that only about 57% of our young adult survivors, when they leave our pediatric clinics, will get engaged into an adult system to continue their survivorship surveillance. And this is important because of the side effects that I have just shown you that occur, and that many of the patients need as a lifelong surveillance plan to be able to help address any late effects that can occur from their cancer therapy. So our team in Atlanta has created a web-based cancer survivor link, which we're making an app for right now, which will equip our patients with the ability to have control over their electronic personal health record and have a survivor treatment exposure history, as well as a survivor plan in place that they can carry with them for the rest of their lives and engage their healthcare provider team to make sure that they're getting the appropriate follow-up and screening for secondary effects that can occur. We're hoping to be able to distribute this nationally to other centers across the country to be able to use in their survivorship programs as well. So as we wrap up, just a couple of opportunities and recommendations to consider. The first, I'll just comment upon the fact that pediatric cancer is different from adult cancer. The type of cancers that we see, the biology of the cancer is different, the treatments are different, the protocols that we use vary from pediatric to adult cancer. If you look nationally in terms of dollars that go into looking for new treatments and cures for pediatric cancer, about 4% of the research funding from the NCI goes directly to pediatric cancer, with the majority of it going to fund adult cancer research. So we want to just continue to say that we'd like to think about opportunities for increased awareness for pediatric cancer and to make sure that we're advancing new therapeutics for children with cancer as well. Just to comment about some other states that have addressed this issue and specific initiatives that have been taken up to make sure that pediatric cancer awareness remains top of mind across the state. Kentucky initiated a pediatric cancer trust fund to support childhood cancer research of $36 million, and Florida made a similar initiative of $37 million in 2024. In Texas, there's a $6 billion initiative that addresses adult and pediatric cancer, with $474 million of it being focused to pediatric cancer research. And in Pennsylvania, there's a voluntary contribution on your tax return, and about $4 million was devoted specifically to pediatric cancer research. So within Georgia, some opportunities to think about. One is improved education. We talked about obesity and exercise, how important that is for responding appropriately to the treatment that we have. Insurance education initiatives, HPV vaccine awareness, enhanced screening for cancer predisposition across the state to make sure that we're taking care of not only the patient, but also the patient's families, including the siblings. The access to care, how important it is to get access to Medicaid and insurance to be able to provide the care that we need in a timely manner, to have social workers and financial navigators to assist our patients, to make Medicaid access and simplified enrollment available to our patients, and to make sure that we can continue to fund these high-cost medications. So as we close the gap on this 20% and look for less toxic therapies, we have to make sure that these treatments are available to all patients within Georgia, not just the ones that have private insurance, but that we can treat everyone that we see that would benefit from these type of therapies. So thank you again for the opportunity to speak today.
Thank you, Dr. Graham. With this time, I would like to again thank our host, University of Augusta, and all your kindness to us in allowing us to be here. I'd like to thank our presenters. Thank you for the great information. I want to thank our legislative members on this committee and our non-legislative members and providers of information and health to our state. Although this is the conclusion of this study committee, is not the conclusion of our study and interest into these subjects of cancer care and access in the state. It's very important. I think we're just at the beginning and scratching the surface of what we can do, where we can be in this state to address this very important disease. We've come a long way. We're still burning with radio oncology, and we're still cutting out with surgical oncology, but we've heard from so many of the providers and researchers into the future of treating cancer and immunosuppressants and things of that nature, and immunotechnology. Again, I would like to thank our presenters and all the people that are on this committee. I'd like to thank our budget and research person, Morgan Hall, and Graham Stewart in my office. I would like to thank Legislative Council for being here and Media Services for all your work over the last 2.5 months that we've been having these meetings. I would like to also tell the committee that we would like to have your comments, thoughts. Morgan will be doing a report in the next week or so. If you can send her to her email any thoughts that you have, any suggestions you would like to have placed in that report, we would like to have those and consider that. Also, as a side, if you could make either a second list of things that you would like for us to look at in the future. Because it's so very important that when we do these study committees, that we continue our work and not just draw a line at the end and sort of forget what we've learned and not apply what we've learned and the possibilities of what we can do to help the people of this state. That's vitally important. So if you can do that also, I'd appreciate that. We'll be looking this over all the information coming in, and your input's so very important. And also in conclusion, we do have some of our presenters still here. And if you would like to ask them questions and speak with them after this would be a good time. We are going to do a tour of the hospital, and say, let's do that around 12 o'clock. So you've got about 20 minutes to take a break and also speak to these presenters. Again, thank you all for being here, and thank you for your participation.